отговорност се обръщаме към най-сигурното нещо, което съществува. Науката. Науката може да пребори заболяванията, да открива лечения и да побеждава пандемии. Правила го е преди, ще го направи отново. Защото когато се срещне с ново предизвикателство, науката не се отказва, тя атакува и задава въпроси, докато не намери отговорите. Това е силата на науката. Затова даваме тласък точно на науката и я развиваме. Нашите проучвания, експерти и ресурси, всички усилия са насочени към развитието на потенциални терапии и ваксини. Другите компании и академичните институции правят същото. Цялата световна научна общност работи заедно, за да се справи с предизвикателствата и всички ние използваме науката, за да помогнем това да се случи. Защото ако науката спечели, печелим всички.
More than 40,000 Teva employees who wake up every morning can be counted, as can the number of production sites in which they work around the world. What can't be counted is their motivation to enable someone, somewhere, to live better days with their loved ones. That's what counts. Teva provides 35,000 products to patients, more than any other pharmaceutical company. Every day, we deliver Teva medicines to pharmacies and hospitals in more than 60 countries. These are numbers we take pride in. But what really counts is our vast contribution to humanity. Our generic medicine saved hundreds of billions of dollars in healthcare costs over the past decade. We enable access for millions of people around the world to quality medicines. For over 100 years, Teva has pioneered scientific explorations, establishing 25 cutting-edge research centers and strategically investing in biopharmaceuticals to the benefit of current and future generations. Today, our innovation has led to more than 1,000 generic medicines being developed. These are all impressive numbers that can be counted. But what counts the most is the positive impact we make on 200 million people every day who can have access to a wider range of medicines to address their health needs. Cherish the priceless times together and live better days.
Good morning, everybody. We are starting the third day of Sophie Echo Days, which is topic is congenital heart disease. It's my pleasure to introduce my co-chairs this morning, Professor Wiley and Professor Ian Ho from Royal Brompton Hospital. The first session for this morning is very interesting, and the topic is about the transposition of great arteries. It's my pleasure to give the opportunity of Professor Ian Ho to present the morphology of this pathology in the adults, and also to chair that the session will be presented from the two young fellows from Johns Hopkins Hospital, and we will inviting some of them to be online this morning for discussion. So, Professor Ho, you are.
So this session is on transposition of the great arteries, and I'm going to speak about the morphology of this entity. So to start with then, transposition of the great arteries, or TGA for short, it doesn't really mean very much if we just say TGA, because it's rather vague. So for the purpose of this talk, I'm going to focus primarily on complete transpositions of great arteries, but I will also introduce a little bit about congenitally corrected transposition. So to begin with then, complete transposition, or TGA for short, or DTGA in North America, the definition of this entity is that in terms of segmental arrangement, we can have either usual atrial arrangement or mirror image atrial arrangement happening with concordant atrioventricular connections. That is to say, the atrial chambers are connected to the correct ventricular chambers, but discordant ventricular arterial connections, meaning the wrong great arteries are coming off from the ventricular chambers. By contrast then, congenitally corrected transposition, also known as CCTGA or LTGA, is a combination of usual atrial arrangement or mirror image atrial arrangement in combination with discordant atrioventricular connections plus discordant ventricular arterial connections. In other words, both levels are incorrect. So two wrongs make a right in this entity. That is to say, physiologically speaking, there is nothing wrong with this heart, apart from the chamber connections being wrong on this side and wrong in the outflow tract. And indeed, in very old literature, you may come across the occasional case report of incidental finding of this entity in autopsy series. So, in other words, a patient with this combination of lesions without any other associated malformations may indeed live to a ripe old age. So this entity then, congenitally corrected transposition, will be shown in those with usual atrial arrangement, a reversed offset arrangement of the atrioventricular valves. In a normal heart, we expect the left-sided atrioventricular valve be inserting at the septal level higher than the right-sided atrioventricular valve. But in congenitally corrected transposition with usual arrangement of the atrial chambers, so-called situs solitus, there is the reversal of this arrangement of the atrioventricular valves at the septum. And here we see the outflow tract, the right-sided ventricle giving origin to the pulmonary trunk. Morphologically, it is the left ventricle. So let's leave congenitally corrected transposition aside and focus on complete transposition instead. So as we said, the definition is that you have the wrong great vessel coming from the ventricular chamber. Clinicians talk about simple complete transposition, meaning intact ventricular septum with no major associated malformations, or complex complete transposition with various complicating lesions, etc. So to start with, look at the great artery arrangement, already abnormal situation. The right sided atrium, the fossa over fossa here, opening to a right ventricle, tricuspid valve, septal leaflet. And this right ventricle giving origin to the aorta. You see the coronary orifice just visible there. And on the left side, left atrium into a left ventricle, very smooth upper part of the septum, and left ventricle giving origin to the pulmonary trunk and pulmonary bifurcation. In this one, there's an intact ventricular septum, as we see here in longitudinal cut, and the septum may appear rather straight, and we have a kind of parallel arrangement of the great arteries, usually, but not always. So simple transposition is listed here, but this entity may not be so simple. For example, there may be variability in coronary arteries, indeed arterial relationships, and in fundibular morphology, and so on. In contrast, the complex form would have lesions such as ventricular septal defect, which is pretty common, about 75% with malalignment of the outlet septum, bringing further complications, subpulmonary obstruction, subaortic obstruction, and coarctation, valvar anomalies, and so on. So we'll review some of these examples. So this is hard. Again, you see the more or less parallel arrangement of the great arteries open up. And we see aorta, pulmonary trunk. We begin to see a ventricular septal defect. Here's the outlet septum, rest of the ventricular septum in alignment. And here, the four-chamber kind of orientation, ignoring this sutures and baffles up here. We see the right ventricle, left ventricle, the right ventricle very much hypertrophied compared to the left ventricle. When the atrioventricular attachment of the valve, this offset arrangement, is as normal, although a little bit lessened if one looks very carefully. And this is an example of right ventricular outflow tract obstruction. Look into the right ventricle, open up, we see the ventricular septal defect here. Here's the outlet septum protruding into the right ventricle. Turn to the left side, we see the pulmonary valve up here, a little bit leaning across the ventricular septal defect. So in long axis cut, this is what we see here. Septum, pulmonary trunk, pulmonary valve, a little bit coming off from the left, right ventricle, outlet septum, and subaortic muscular infundibulum. So further upstream then, we might anticipate to find some more obstructive lesions such as a coarctation associated. By contrast then, in this case, the right ventricular view does not show the outlet septum. There's a ventricular septal defect here. Instead, the outlet septum is deviated into the left ventricle, as we see here. Here's the pulmonary valve, ventricular septal defect, mitral valve. So it's pushing into the left ventricular outflow tract, giving subpulmonary obstruction. A longitudinal cut here shows you that the outlet septum narrowing the aortic outflow tract, the pulmonary outflow tract, which is sandwiched between the outlet septum and the anterior leaflet of the mitral valve. But there may be other substrates to left ventricular outflow obstruction, as we see in this heart. Right ventricle opening up and left ventricle open up just there. Here we see the pulmonary valve, mitral valve, kind of dysplastic looking, but a bulge in the ventricular septum. So subpulmonary obstruction due to a septal bulge. And as we said before, it's important to look out for coronary artery anomalies. This is the usual pattern that we find in complete transposition of the great arteries. 69% with the left coronary artery coming from this aortic sinus that's nearer to the front, and the right one coming from the more posteriorly located aortic sinus. Less commonly, this configuration with the circumflex artery coming from the right coronary artery. But when the great arteries are either at directly anterior-posterior relationship or side-by-side relationship, there tends to be more complications arrangement in the arrangement of the coronary arteries. For example, in this one here, we see the right coronary artery giving the circumflex artery over here, but here we see a coronary orifice which is more or less obliquely through the aortic wall and very near to the commissure between two of the aortic leaflets. And this one comes up here and gives the branches to the right ventricular infundibulum, as well as an anterior descending coronary artery, and associated another anterior descending coronary artery back there. So this is an example of having had anatomical correction or arterial switch procedure with extension of the new pulmonary valve or pulmonary trunk, pulmonary bifurcation brought forward. And here the aorta has been pushed back and attached to the original pulmonary trunk. And here we see the buttons of the coronary arteries implanted to the base of the original pulmonary trunk. In this case here, there's 4 years post arterial switch procedure. We see the suture line here, and here we can just about make out the coronary buttons that have been used to reimplant the coronary arteries back to the native pulmonary valve, converting the native pulmonary valve into a new aortic valve. And these are not entirely problem-free. There have been case reports of the percentage of individuals having had post-arterial switch procedure with some sort of thickening or stenosis of the proximal course of the coronary arteries. But these are quite dated literature by now. So these might have been kind of historical reports nowadays. So the native pulmonary valve in complete transposition becomes the new aortic valve. And this is our post-mortem series, about 38 specimens, showing some variations in arrangement of the native pulmonary valve. So maybe disproportionate, maybe it would be unicuspid and stenotic. The other procedure then, in more popular decades ago, is that of the atrial switch procedure. There are two main types. So essentially, taking away the atrial septum, most of the atrial septum, and switching the flow across that atrial level to the lungs and to bodies. So this is an example of a post-mustard. This trouser-shaped baffle, as we see here, routing the superior and inferior cable return into through the mitral valve to the left ventricle. We see a patch used to enlarge the right-sided atrium, and looking into the right-sided atrium, we see the legs of this trouser-shaped baffle. This one leg over the orifice of the inferior cable vein. This is the other leg over the orifice of the superior cable vein, and the pulmonary veins would then run over the top of this baffle in through the tricuspid valve into the right ventricle. That is this area here. Now, this is an example of post-Mustard's procedure, which showed then a very narrowed area where the pulmonary venous return has to come through in order to pass over the baffle. This area is the baffle, over the baffle into the right ventricle. And of course, after atrial redirection, you can end up with the right ventricle becoming a systemic ventricle. It is supporting the aorta, of course. And this is one of these cases, a very enormously enlarged heart, a systemic right ventricle. It was thickened before. I think it's gradually become thinner. And on histology, we see interstitial fibrosis and microscar in this ventricle. So that takes me through, I think, primarily complete transposition of the great arteries. And just to emphasize that simple is not so simple. You can have arterial switch and you can have atrial switch. So thank you for your attention.
Thank you, Professor Ho, for the very interesting introduction of this topic. I know that there will be questions, but maybe we will continue with the clinical part and echo methods for the analyzing this kind of patients, and then we could combine with the morphology and echocardiography findings. So it's my pleasure to introduce the next speaker. This is the Dr. Ani Doshi. She will present the echocardiography assessment of transposition grid artery before repair and after atrial switch repair and arterial switch repair.
Hello, my name is Ashish Doshi of Johns Hopkins Children's Center in Baltimore, and I'll be discussing initial echocardiographic assessment of transposition of the great arteries. I have nothing to disclose. First of all, the talk and the subsequent one on postoperative assessment and transposition of the great arteries are an introduction to echocardiographic assessment of this disease. For a thorough review, see the excellent guideline paper from the American Society of Echocardiography, available online for free at asecho.org. For this talk, we'll be discussing simple transposition of the great arteries, that is, circumstances in which the major hemodynamic defect is due to the great artery arrangement. I will not be discussing complex congenital lesions such as tricuspid atresia or double outlet right ventricle, in which the great arteries happen to have an abnormal arrangement. Now, many refer to this disease as D transposition of the great arteries, although it's not immediately clear what the D refers to, and a more specific name would be D-looped transposition of the great arteries, making it clear that this is referring to transposition of the great arteries with normal D-looped ventricles, the D coming from the Van Praagh School of Nomenclature. And this is in contrast to L transposition of the great arteries, or L-looped transposition, in which the ventricles have inverted arrangement. However, the term D-looped TGA is still not 100% accurate, as a patient with situs inversus totalis with this disease would have segmental anatomy of ILL. So the same physiology, but referring to them as DTGA would not be accurate, and referring to them as LTGA would imply a different physiology. And so the best approach really is to describe the anatomy completely, either stating transposition of the great arteries SDD in the Van Praagh system, or mentioning ventriculo-arterial discordance and atrioventricular concordance in the Andersonian system. That said, for the sake of this talk, I will be using the term DTGA for the sake of brevity. I will not be discussing LTGA. That will be covered by my colleague, Dr. Torres Vieira. But I will mention that LTGA is also not the most specific name, nor is anatomically or congenitally corrected TGA the most specific. And again, the most specific nomenclature is to simply describe the segmental anatomy using Van Praagh or Andersonian system. So I'm going to discuss the relevant anatomical features in transposition, the imaging goals, the imaging protocol, and the views used to obtain those images. Now, with respect to the anatomical features in transposition, about 55 to 60% of cases have an intact ventricular septum. And in this situation, the systemic and pulmonary venous connections are normal. There's typically a left aortic arch without obstruction. And few of them have any type of aortic or pulmonary valve stenosis. The PFO and ductus arteriosus are typically present at birth. But with intact ventricular septum, the patient may need a balloon atrial septostomy to alleviate severe cyanosis. In about 40 to 45% of cases, there's a ventricular septal defect that can complicate surgical repair, both by adding another defect to the repair as well as resulting in anatomic changes that may limit the ability to perform an arterial switch operation. And so of these cases with ventricular septal defect, about 1/3 of them are a paramembranous VSD, and this is similar to any other paramembranous VSD in patients without transposition of the great arteries. They can be large, they can be small and restrictive, they can have be partially closed by accessory tricuspid valve tissue. About 30% of TGA patients with a VSD have a malalignment defect. These are typically large and unrestrictive. With anterior malalignment of the caudal septum, there's obstruction of the right ventricular outflow tract. And typically we think of this in other cases as causing pulmonary obstruction, but of course with transposition, RVO obstruction causes subaortic obstruction, aortic valve hypoplasia, or coarctation or interruption of the aortic arch. In contrast, posterior malalignment of the caudal septum can cause LVOT obstruction, which again with TGA means subvalvular or valvular pulmonary stenosis. In about 25% of cases of TGA with VSD, there's a muscular defect. These are frequently multiple, typically in the mid-muscular septum, but can appear anywhere in the muscular septum. These may close spontaneously or become restrictive spontaneously. And less common are atrioventricular canal or inlet defects. These may involve a tricuspid valve straddling the ventricular septum. There may be RV hypoplasia involved, and these may limit the ability to perform an arterial switch procedure. Also rare are outlet or subpulmonary VSDs. And there's deficiency of the conal septum between the aortic and pulmonary valves. And so closure can be difficult. The surgeon will have to place a suture in the fibrous rim between the aortic and pulmonary valves. And this may distort the semilunar valve rims. Now, as opposed to the normal great artery arrangement in which the aortic valve is posterior and rightward of the pulmonary valve in detransposition of the great arteries, the aorta is anterior and rightward of the pulmonary valve. And this can range from a strictly anterior-posterior arrangement to a left-right arrangement, although typically it's somewhere in between. Defining the coronary artery arrangement in TGA is essential in preoperative imaging to understand the feasibility of coronary artery transfer during the arterial switch operation. And there are two systems to describe the coronary artery arrangement. The first is using the typical echocardiographic or diagnostic imaging convention, that is viewing the valves from the inferior surface. Now, if the semilunar valve arrangement is oblique, we typically define a left anterior and right posterior facing sinus and describe the corresponding coronary arteries. For example, we would say the left main, left anterior descending, and left circumflex coronary arteries arise from the left anterior facing sinus, and the right coronary arises from the right posterior facing sinus. If the semilunar valves are anterior posterior, we'll define a left facing and right facing sinus. And if they're side by side, we'll define an anterior facing and posterior facing sinus. Now, there's also the Leiden convention, which is more useful for the surgeons who are viewing the valves from above and looking at the great vessels in relation to each other and not in relation to the anterior, posterior, or left, right anatomic planes. And the way to think of this is to imagine standing in the aortic sinus that's farthest from the pulmonary valve here, and standing from the superior end. And sinus 1 is on your right-hand side, and sinus 2 is on the left-hand side. Now note this may be the opposite of the anatomic right and left. And so here, for example, sinus 2 is the right-handed sinus, which is actually on the patient's left side because we are facing posteriorly toward the pulmonary valve. Now, after defining sinus 1 and 2, the coronaries that arise from that sinus are listed. For example, in this so-called usual coronary artery arrangement, the left anterior descending and left circumflex coronary arteries arise from sinus 2. So we have, sinus 1, which is the right-facing sinus. And so we have 1L circumflex, and then sinus 2, which is the left-facing sinus, or the left-handed sinus, rather. We have the right. Now, regardless of which system is used, it's important to have a common language within a congenital heart center, especially with respect to communication between the cardiologist and the cardiac surgeon. These are the typical patterns of coronary arrangement in DTGA, the so-called usual coronary arrangement in which the left system arises from the left or anterior facing sinus and the right coronary artery arises from the right or posterior facing sinus. This is the most common, with 65% of patients having this arrangement. Second most common is the left circumflex arising from the right coronary artery, and followed by the third most common, which is a single coronary artery from the posterior facing sinus or sinus 2. Together, these three make up over 85% of the coronary artery arrangements, with some more unusual arrangements listed here. With respect to the initial study, there are several things we need to delineate. First, we need to confirm the segmental anatomy, the systemic and pulmonary venous connections, as well as the ventricular looping, confirm that this is D-loop transposition. The atrial septum, including any atrial septal defects, atrioventricular valve morphology and function, the ventricular size and function. This is partially to confirm that a two-ventricle repair can be performed. Ventricular septum to identify those ventricular septal defects. Again, of course, obviously the ventricular arterial connections to determine any presence of outflow tract obstruction, stenosis or valvular regurgitation, the semilunar valve arrangement and coronary arrangement, as we discussed previously. And then finally, we want to visualize the ductus arteriosus and identify any aortic arch abnormalities. The views we use for these include the subcostal view, which will show us the segmental anatomy, the atrial septum, the ventricular septum, the outflow tracts, and the great artery arrangement. In the peristernal view, we can also visualize the great artery arrangement. We can see the vessels in long axis, and in short axis, we can see the semilunar valves, as well as the coronaries, and whether the commissures of the semilunar valves are aligned. We can also identify the ventricular, we can also sweep through the ventricular septum to identify any ventricular septal defects. In the apical short chamber view, we can visualize the ventricular size and function, look for atrioventricular valve stenosis or regurgitation, and also for outflow tract obstruction. And then finally, from the suprasternal notch, we can visualize the ductus arteriosus and the aortic arch. So these are subcostal views of a patient viewing the atrial septum. Here's the left atrium, right atrium. We see a secundum atrial septal defect with left to right flow. The subcostal view is also useful for echocardiographic guidance of balloon atrial septostomy. Here we have a septostomy balloon crossing from the right atrium to the left atrium and being inflated. And in the second view on the right, we see the septostomy balloon being pulled across. This is the same patient. This is a second pull, a little bit more gentle this time. And then finally, we can visualize the final result of the atrial septostomy. Here we have an aneurysmal atrial septum and two atrial septal defects. From the peristernal long axis, we can see the great vessels in long axis. Here's the aorta anterior and the pulmonary artery posterior. This is a useful valve for defining the aortic and pulmonary valve annulus sizes to confirm that an arterial switch can be performed. We can also see any VSDs in this view. Here's a VSD here. We can also look to see if there are malalignment VSDs. And so here we have an anterior malalignment VSD. This is the pulmonary valve that is displaced anteriorly. The aortic valve is not seen here, but again, with anterior malalignment, we have RVOT obstruction, which is the aortic outflow. And in this second view here, we have posterior malalignment of the ventriculars of the conal septum. And so we see that this is the aortic valve anterior here, and this is the pulmonary valve, which is slightly hypoplastic because of the posterior displacement of the conal septum. The peristernal short axis is useful for semilunar valve arrangement. This is kind of, again, the kind of oblique arrangement of the aorta anterior and rightward, and the pulmonary valve posterior and leftward. This is more of the anterior posterior arrangement where the aortic valve is directly anterior, and then a more of a left-right arrangement where the aortic valve is directly rightward of the pulmonary valve. Here in this one, in the side-by-side view, we can actually see that the commissures for this patient are not well aligned, and this will complicate the coronary artery translocation during the arterial switch operation. The coronary artery here from the anterior facing sinus will have to be transplanted slightly farther to actually implant in the sinus here to go past the commissure. In the peristernal short axis, we can also define the coronary arteries. This is a patient with usual coronary artery arrangement. So here is the left anterior descending and left circumflex coronary arteries arising from the left anterior facing sinus. And then here from the right posterior facing sinus, we have the right coronary artery. Here is a patient with a circumflex arising from the right coronary artery here. Again, this is the second most common type. And from the apical views, we can assess ventricular size and function. We can look for mitral or tricuspid stenosis or regurgitation. We can also look for outflow tract obstruction. Here is a patient with anterior malalignment of the coronal septum and anterior malalignment VSD. And we can see that there's outflow tract obstruction of the aorta here. And here's a patient with posterior malalignment VSD, and you can see that the pulmonary valve has some subvalvular and valvular pulmonary stenosis. Finally, from the suprasternal notch view, we can assess the pulmonary patent ductus arteriosus and aortic arch. So here's a patient with a normal aortic arch, and we can see that the ductus arteriosus is flowing all from the aorta to the pulmonary artery, both in systole and diastole. And in contrast, here's a patient who has a anterior malalignment VSD, and as a result of that, has a aortic coarctation, which we can see on 2D echocardiography here. But also we see that during ventricular systole, there's pulmonary artery to aortic flow in the ductus arteriosus, indicating that there's obstruction proximal to that insertion point. So in summary, DTGA seems like a simple disease, but does require a thorough preoperative imaging study with particular attention to the atrial septum, the ventricular septum, presence of any outflow tract obstruction, semilunar valve arrangement, coronary arrangement, and the ductus arteriosus. If there's concern for RVOT obstruction, one must also be sure to assess the arch as well. Thank you very much for your attention. Hello, this is Ashish Doshi, and I'm going to be speaking to you again today about echocardiographic assessment of repaired transposition of the great arteries. Again, I have no disclosures. The mustard procedure and the sending procedure, collectively known as the atrial switch operation, was the standard approach to repair DTGA until the mid-1980s. Using an intra-arterial baffle, the systemic venous return from SVC and IVC is routed to the mitral valve, and the pulmonary venous return is routed to the tricuspid valve. The right ventricle then serves as the systemic ventricle, pumping into the aortic valve and the body, whereas the left ventricle serves as a subpulmonary ventricle. The mustard or sending procedure could be performed later in infancy and does not involve manipulation of the coronary arteries. In contrast, the arterial switch procedure provides a more anatomic and physiologic correction of TGA, but does involve the technically difficult transfer of coronary artery origins. Additionally, the procedure must be performed in the first few weeks of life before the left ventricle loses muscle mass from pumping against the low resistance pulmonary vascular bed. Because of the additional technical difficulty, the arterial switch initially had a higher early mortality rate compared to the atrial switch, although with improvements in surgical and perioperative care, early mortality for the arterial switch operation is now well below 2% in the developed world. Additionally, the atrial switch has a higher late mortality due to systemic right ventricular failure. This plot shows the gradual adoption of the arterial switch operation at a high volume center in Munich, and is similar to the adoption of the arterial switch in the rest of the developed world. And most patients today living after an atrial switch in the developed world are over the age of 30. However, the atrial switch is still being performed in resource-limited countries. This is a study from 26 sites in 15 countries from the International Quality Improvement Collaborative for Congenital Heart Surgery in developing world countries. In this cohort, atrial switch was performed in 1 out of every 7 to 8 patients with transposition of the great arteries during the period of 2010 to 2013. In-hospital mortality was lower for the atrial switch compared to the arterial switch, particularly when there was a VSD involved. The third column here, 2S ASO, indicates a 2-stage arterial switch in which the patient initially undergoes placement of a main pulmonary artery band to provide a high afterload to the LV, such that it would not atrophy over time. And this allows for the arterial switch to be performed at a few months of age, at which time the procedure may be more feasible due to the increase in the patient's size. Now, of note, there are other surgical procedures for TGA when there is outflow tract obstruction, such as the Rastelli procedure, the REV procedure, the Nakaido procedure. I will not be discussing those in this talk. When evaluating a patient with an atrial switch, that is a muster or sending procedure, the main sequelae to evaluate on echo are the presence of systemic or pulmonary baffle obstruction, the superior limb of the systemic venous baffle, that is from the SVC, is the most common site of obstruction, particularly in patients with a transvenous pacing lead in the SVC. Baffle obstruction is more common with the muster procedure compared to the sending procedure, since the muster procedure uses prosthetic material for the baffle. The superior limb of the SVC baffle, the superior limb of the systemic venous baffle is well visualized from the apical view, as is the pulmonary venous baffle. The inferior limb, that is the IVC limb of the systemic venous baffle, is not very easily visualized by echo, but it is rarely obstructed due to the relatively large size of the IVC. Baffle leaks can occur between the pulmonary and systemic venous baffles, primarily at the anastomosis of the baffle with the atrial wall. Physiologically, these leaks act as a left to right shunt with flow from the pulmonary venous baffle to the systemic venous baffle. These can be identified using color Doppler, but if the imaging windows are not adequate to visualize the baffle, one can use injection of agitated saline or even TE. Tricuspid regurgitation can result from annular dilation and is problematic, as the tricuspid valve is the systemic atrioventricular valve. This can worsen right ventricular dysfunction. And of course, as the right ventricular anatomy is not designed to pump against systemic vascular resistance for several decades, the systemic RV is at high risk for dysfunction and failure. Unfortunately, due to the complex shape of the RV, we lack validated quantitative metrics for RV function. There are various methods such as tricuspid annular plane systolic excursion, TAPSE, fractional area change, global longitudinal strain, but none of these have been really validated in this population. And all of them need to be interpreted in the context of the degree of tricuspid regurgitation. Often, qualitative assessment is still the preferred method of assessment. Finally, pulmonary hypertension can result due to pulmonary venous baffle obstruction or due to right ventricular failure. And to evaluate the pulmonary arterial pressure, we measure the peak velocity of the mitral regurgitant jet, since the LV is a subpulmonary ventricle. So this is the apical four-chamber view showing the systemic right ventricle and the subpulmonary left ventricle. We also see the pulmonary venous baffle here, which is better seen with color Doppler. You see the pulmonary venous flow coming across and into the tricuspid valve. Over here on the right side, we see the systemic venous baffle, the superior limb of the systemic venous baffle coming over to the mitral valve. Again, the inferior limb of the systemic venous baffle is often not well visualized, but is rarely obstructed. Here's another patient with a better image showing the pulmonary venous baffle here and the superior limb of the systemic venous baffle. Here's the actual baffle itself, separating the systemic and pulmonary venous return. And as we tip anteriorly, we see this flow from the pulmonary venous baffle into the superior limb of the systemic venous baffle, representing a baffle obstruction. A baffle leak. Here's the systemic right ventricle with the tricuspid valve, and with color Doppler, we see tricuspid regurgitation. Here's a patient with severely decreased right ventricular function. We can see that there's a transvenous pacing lead crossing the mitral valve into the left ventricle, and there's a significant amount of mitral regurgitation. If we obtain a Doppler tracing of the mitral regurgitation, we can obtain an estimate of the left ventricular systolic pressure, which is again the subpulmonary pressure. So this gives us an indication of the pulmonary artery pressure. Now moving to our arterial switch, the following sequelae can be evaluated with echo. Coronary artery stenosis due to occlusion or kinking after coronary translocation and is an important cause of early mortality after the arterial switch. It should be evaluated in the immediate postoperative period, as well as in any patient with new wall motion abnormality or any signs of ischemia. The long-term fate of these reimplanted coronary arteries is not really well known, as the earliest arterial switch patients are only now in their 5th decade of life. And so in all arterial switch patients, it's important to assess ventricular function, including evaluating for regional wall motion abnormalities. Supravalvular neopulmonary stenosis can occur typically at the site of the anastomosis. Additional branch pulmonary artery stenosis can occur due to the Lecomte maneuver, in which the branch pulmonary arteries are pulled anterior to the ascending aorta and draped on either side of the ascending aorta. And this stretches them somewhat, particularly the left pulmonary artery. Supravalvular neo-aortic stenosis can also occur at the suture line. This is best assessed from using the right upper sternal border view. Progressive neo-aortic root dilation is common, although it rarely leads to morbidity or any kind of need for a reoperation. The diameter of the neo-aortic root should be measured in the peristernal long axis in the standard fashion. And then finally, neo-aortic root regurgitation is, neo-aortic valve regurgitation is common, but severe regurgitation occurs only in 1 to 2% of patients. These are transesophageal echocardiogram images from an arterial switch operation performed recently at our institution. On the left image, we see the reimplanted short left main coronary artery, which bifurcates into circumflex and left anterior and descending. And then on the right image, we see the right coronary artery, and both of them have normal antegrade flow and diastole. Supravalvular neopulmonary stenosis can be evaluated in the apical or subcostal views with the probe tilted anteriorly or rightward. And so these top two images show the subcostal short axis or parasagittal view with the aortic valve on the patient's left and the pulmonary valve on the patient's right. And we see this narrowing on 2D and corresponding aliasing on color Doppler. In the peristernal long axis view, linear echo density is seen here, likely representing the suture line, and we see corresponding aliasing at that level. We also see some trivial neopulmonary regurgitation here. Branch pulmonary stenosis is best evaluated in the high peristernal short axis, and in many patients this can be difficult to visualize as they're so close to the transducer. But these images are from an infant who underwent arterial switch with the Lecomte maneuver 2 months prior. And so in this image, the branch PAs are seen draping over the ascending aorta here. With color Doppler, we see aliasing the right pulmonary artery as well as in the left pulmonary artery. And so, as mentioned, the left pulmonary artery is the one more commonly has branch pulmonary artery stenosis due to the main pulmonary artery being pulled anteriorly and rightward during the arterial switch, and that results in increased tension on the left pulmonary artery. Supravalvular neo-aortic stenosis can be difficult to visualize from the apical or the peristernal views, but an accurate Doppler measurement of the ascending aortic valve gradient can be obtained from the suprasternal view here. And finally, progressive neo-aortic root dilation is common after the arterial switch, but it rarely results in morbidity or a need for reoperation. The risk factors for root dilation include the presence of a VSD and the previous pulmonary artery band, potentially as part of a 2-stage arterial switch procedure. Neo-aortic valve regurgitation can be seen, although as mentioned previously, it is rarely severe. And so this patient has trivial to mild neo-aortic valve regurgitation and some mild neo-aortic root dilation. So in summary, echo assessment following the atrial switch should focus on the assessment of the atrial baffles, as well as assessment of the right ventricular function and tricuspid regurgitation. Following the arterial switch, the assessment should focus on the supravalvular aortic and pulmonary areas, the branch pulmonary arteries, as well as the aortic root. And coronary artery origins and ventricular function should always be considered in these patients, particularly when they present with signs of ischemia or regional wall abnormalities. Thank you very much for your attention.
Thank you for the nice presentation, Dr. Doshi. I think we could, starting with the small discussion, I would like to invite Professor Ho. There is no still question, but I think we'll could analyze how is going actually with the right ventricle after the switch, arterial switch and atrial switch, because the right ventricle is more damaged in that population.
With atrial switch, we already know that the right ventricle becomes a systemic ventricle, and it does have long-term consequences, as we see in histology. There's increased fibrosis and so on, which is not really helpful to the ventricle myocardium. In terms of atrial switch, I think you would get away because your ventricles are now back to what they're supposed to be doing. So unless you got further upstream obstructive lesions, I think you would be fine. Although I have no information whatsoever on that front.
Yes, the systemic right ventricle more or less is damaged from the fibrosis, and but that fibrosis, I think, more or less it's connected with the left ventricle also, and we could find some of the measurements with the patients that we analyzed in our hospital a couple of years ago, especially for the great transposition, that the left ventricle is also damaged from, especially from some of the segments, and the septal and the anteroseptal wall, from that fibrosis in the right ventricle, which is evolved.
It could, of course, be more widespread, because the ventricles have to work together, isn't it? I mean, if you damage one ventricle, you're going to have consequences on the other ventricle.
Yes, I don't see the Professor Lee is here, but
I think she has to do some echoes, yeah. Apparently.
Okay.
Yeah.
And because there is one small question from yesterday, which we see now today, and but it's very nice to have the answer. How could we differentiate the inlet perimembranosus VSD from IVSD with only ventricular communication, since both have no offset? I think it's very difficult to analyzing this type of communication when we have the actually only the echo.
I think so. I think it would be difficult, because we would say that if you have a perimembranous inlet VSD, you have the two valves on the top of that VSD. Yeah. So to distinguish that situation from an atrioventricular septal defect that has only interventricular communication, we would anticipate the leaflets to be attached to the underside of the atrial septum. So true, the image you will see will be exactly the same on four-chamber orientation. But if you were to go on short axis and you look up and look at the valve arrangement, you would not find a mitral valve in an atrioventricular septal defect. So I think that would be the distinguishing factor.
Maybe the other imaging techniques like the cardiac MRI and CT will be more helpful in that case, actually.
Yes.
Yeah, okay, thank you. Thank you. So I would like to continue with the next presentation. This is the echocardiography assessment in congenital corrected transposition of great arteries. It's my pleasure to introduce Professor Guillermo Vieira from Johns Hopkins Hospital.
Greetings, everyone. My name is Guillermo Torres. I am a pediatric cardiology fellow here at Johns Hopkins, and today I will be discussing the echocardiographic assessment in congenitally corrected transposition of the great arteries. The outline for this talk is to initially describe the nomenclature, morphology, as well as the pathophysiology associated with congenitally corrected transposition. Also describe the most common associated lesions with this defect, describe the pre and post-operative echocardiographic assessment goals, and then also some special considerations when we're imaging the adult. Regarding the background of this lesion, so it's referred to a set of connections whereby the vena cava actually connect to a morphologic right atrium, but this right atrium actually enters into a morphologic left ventricle, which is right-sided, via the mitral valve. This LV then ejects into the pulmonary artery, and then pulmonary venous return is actually normal and empties into the left atrium. This atrium empties into the morphologic right ventricle, which is left-sided via the tricuspid valve, and then the RV ejects into the aorta. Regarding nomenclature for congenitally corrected transposition, that has multiple names and it's very confusing. It may also be known as isolated ventricular inversion, double discordance, referring to both the atrioventricular as well as the ventricular arterial discordance. It may be physiologically corrected transposition, emphasis on physiologic correction since not anatomic. The RV is the subaortic ventricle supporting systemic circulation, and then the LV is the subpulmonary ventricle, giving rise to the pulmonary trunk. It may also be referred to as L transposition. This is a non-specific term, as the L might be related to ventricular looping or to the actual spatial position of the great vessels. L loop, TGA, would be more specific, where the L loop refers to the ventricular looping. Here we have some features that suggest CCTGA on the apical fourth chamber seen on the left. They have a presence of a left-sided atrial appendage, which then drains into an enlarged and coarsely trabeculated chamber with septal attachments, which are suggestive of a morphologic right ventricle. On the right, you have an image to compare and for kind of guidance. It's an apical fourth chamber as well, but the transducer has an interior sweep to image the parallel position of the great arteries. Note the leftward position of the aorta in relation to the pulmonary artery with its perfect bifurcation. So morphogenetically, the primitive cardiac tube is anchored at one end by the sinus venosus and at the other end by the truncus arteriosus. It loops to the to the right normally, giving rise to the normal segmental anatomy that we know. In congenitally corrected transposition, this unfortunately doesn't happen, and looping is actually to the left. This abnormal cardiac looping then brings the morphologic left ventricle to the right and the morphologic right ventricle to the left, and usually results in transposed great arterial positions. Associated lesions with congenitally corrected transposition, first and foremost, are ventricular septal defects, which are seen in around 60 to 80% of cases. Here, seen and visualized, it's actually a dextro transposition of the great arteries, but the configuration in regards to ventricular septal defects is actually quite similar. They may be doubly committed, perimembranous, inlet type ventricular septal defects, or muscular. But by far, the most often is the perimembranous ventricular septal defect, and it's unrestricted in nature. This, in terms of mechanism, the L looping leads to malalignment of the atrial and ventricular septae. The degree of deviation, therefore, may determine the gap between the septae, and it can actually affect the size and the extent of the ventricular septal defect. Another common associated lesion is the left ventricular, or in this case, pulmonary obstruction, which is seen in around 30 to 50% of cases. The mechanisms leading to this obstruction may be either muscular, with edging of the subpulmonary outflow between the infundibular septum and the free wall, or maybe fibrous, with contribution from the membranous septum or the actual mitral valve or tricuspid valve tissue. Seen here is a subcostal long axis view, focus on the left ventricular outflow tract obstruction with evidence of flow acceleration below the level of the valve. Shown here is a transesophageal echocardiogram in 4-chamber view, demonstrating atrioventricular valve tissue, which actually extends into the defect. Color Doppler is not demonstrated on this view, but you can actually, it would actually show flow acceleration also at the level of the left ventricular outflow tract. Another example here, we have a 9-month-old, so a little bit uncommon. It's more of a pediatric lesion, right? This is an L-loop TGA with segmental anatomy SLL. He had mildly diminished right ventricular systolic function. And then seen here, again, subcostal long axis view focusing on the left ventricular outflow tract with redundant mitral valve chordal tissue in the LVOT without significant obstruction. The actual peak rating here was around 50 millimeters of mercury. Another common associated lesion is left-sided tricuspid valve anomalies. This may also be seen in up to 90% of cases. Tricuspid valve dysplasia is common with an Epstein-like displacement of the septal leaflet, tricuspid valve and/or mitral valve straddling as well. Shown to the left is a typical configuration of Epstein's anomaly. Seen here is rotational displacement of the septal and posterior leaflets, a dilated and thinned inlet portion of the right ventricular myocardium, as well as an anterior leaflet, which is usually quite enlarged or referred to as sail-like. When we're discussing Epstein-like malformation and congenitally corrected transposition, none of these features are persistent. Seen here on the right is an Epstein malformation in a 22-year-old man with severe tricuspid regurgitation. The mechanisms for the regurgitation include tricuspid annular dilation, shortened chordae tendineae, secondary to severe dilation of the right ventricle, also lack of coaptation of the leaflets, and a severely dilated left atrium and right ventricle. This was after a pulmonary artery band procedure. The evaluation of the coronary arteries is also quite essential, and particularly for surgical planning. Most prevalent is what's called a coronary artery to ventricular concordance. The coronary arteries originate from posterior facing sinuses above the aortic valve, and the distribution is actually a mirror image of normal. Shown here is the actual distribution. The epicardial distribution of the right-sided coronary artery is that of a morphologic left coronary artery, with the circumflex and anterior descending coronary arteries. And the left-sided coronary artery follows the left AV groove and supplies the right ventricle. For repairs actually requiring a ventricular to PA conduit, there are some specifications that we should consider. For example, a main coronary branch may course anterior to the pulmonary trunk in about 96% of cases, and a large inframandibular branch supplying the RVOT may be found in around 61% of cases. So what are our goals when we're talking about initial as well as ongoing assessment for congenitally corrected transposition of the great arteries? Most of the assessment and the imaging goals are to establish a first diagnosis. This includes determining the actual visceral atrial situs, the cardiac orientation and position within the thorax, determining the morphology of the ventricles, the morphology of the great arteries, atrioventricular and ventricular arterial connections, origin and proximal course of the coronary arteries, as well as associated cardiac malformations as we just discussed. From a hemodynamic standpoint, it is also important to assess by ventricular size and function, evidence of pressure and or volume load on those ventricles, severity of mitral and or tricuspid valve regurgitation if present, gradient across the outflow tracts, gradient across the VSD, whether it's restrictive or non-restrictive, as well as estimation of the LV systolic pressure based on the mitral regurgitation jet velocity. We'll now go delve a little deeper in a way in terms of how each specific view will be helpful in these endeavors, starting out with the subcostal views, which may be a little difficult when evaluating the adult population. In pediatrics, it's a very valuable view since it provides us an accurate assessment of the atrial arrangement, the atrial and ventricular malalignment if present, ventricular morphology, and it's a very appropriate view for and well-aligned Doppler for estimation of the LV outflow tract obstruction gradients. We may also interrogate LV to pulmonary artery conduits with this view. Apical views, the transducer position according to standard guidelines may be important since there are specific defects in regards to segmental anatomy, which may be influenced by correct positioning of the probe, which we'll talk about a little bit later. Apical views also describe the morphology of the AV valves and also identify morphologic right and left ventricles. Hemodynamic assessment, inflows and outflows of the atrioventricular valves is also appropriate in the apical views, and we may also describe morphology of obstructions across the outflows. Peristernal views, so the parallel position of great arteries seen in the peristernal long axis view in particular usually confirms the diagnosis of transposition of the great arteries. The long axis view readily identifies obstruction across the LV outflow tract and can also shed some light in regards to the actual mechanism of obstruction. Peristernal short axis view describes the relation of the ascending aorta to the pulmonary trunk. Seen here are a couple of snapshots both of the peristernal long axis view and a short axis view. The aorta seen is anterior and the pulmonary artery is posterior, which is our first clue. To the far left is a 41-year-old man without LV outflow tract obstruction. Seen here is the arterial outflow tract palo, and the AV valve is in fibrous continuity with the pulmonary valve as shown by the long arrow. To the right, we have a 9-month-old boy with subvalvular pulmonary stenosis as shown by the small arrow, probably from redundant atrioventricular valve tissue. Again, as stated, imaging in the adult may be quite complicated. So TEE, or transesophageal echocardiogram, is an alternative if unable to delineate cardiac anatomy. In some cases, it is quite useful to consider injection of agitated saline, which may demonstrate appropriate systemic venous return and better delineate the morphologic right versus left ventricle. Cardiac MRI may also be a feasible alternative since it may allow better delineation of the anatomy, assessment of ventricular function, or measurement of valve regurgitation and shunts. So this is a special case of atrial situs inversus. The segmental anatomy here is IDD, or inverted atria, deventricular loop, and detransposition of the great arteries. The left-sided superior and inferior caval veins therefore empty into a left-sided right atrium, and the pulmonary veins empty into a right-sided left atrium. The subaortic RV is not inverted and lies into the right of the subpulmonary left ventricle. The aorta is right-sided and anterior, located in relationship to the pulmonary artery. This patient was a 30-year-old female with congenitally corrected transposition, as previously stated, IDD, dextroversion with atrial and ventricular septal defects. She also underwent a left ventricular to pulmonary artery conduit, not well visualized here and actually better appreciated by cardiac MRI. So possible interventions are either physiologic or anatomic. So physiologic or palliative include VSD closure, the conduit as previously mentioned, replacement or repair of the tricuspid valve, pulmonary arterial banding, or pump support in thinking of possible cardiac transplantation. When considering an anatomic repair, we may do either a double switch, which includes an arterial switch and a mustard sending as shown here, or a Rastelli type repair with a mustard and sending as shown here, in some cases with a LV to PA conduit or RV to VA conduit. Intraoperative assessments, most likely preoperatively confirmation of the defect, and then post-cardiopulmonary bypass, in all cases, just assessment of ventricular size and function. For atrial switch, evaluation of systemic and pulmonary venous pathways. For the arterial switch, function of the semilunar valves and flow into the coronary arteries. When establishing a conduit and prosthetic valves, it's important to verify leaks or obstructions. Just to note, the pulmonary arterial banding during and after evaluation of the right and left ventricular systolic function will be important, as well as mitral regurgitation and gradients across the valves. Thank you very much for the time dedicated for this presentation. Special thanks to Dr. Shelby Cuddy, Professor Katarina Hristova for the opportunity to present today, and the coordinators of the event.
Thank you, Professor Dr. Vieira, for the very nice and very interesting presentation. I'm really sorry that the time differences is not available for us to make the live discussion, but we will continue with the Professor Hall to ask, because there is some questions, and I think that we could make the short discussion about that. So can we explain the course of the conduction in congenital corrected transposition of great arteries? How do you think, Professor Hall?
Yes, the thing is with different terminologies, and now I try and explain. When you have CCTGA, you can have two variations of atrial arrangement. You can have usual atrial arrangement or mirror image atrial arrangement. In other words, situs solitus versus situs inversus. So let's say you have usual atrial arrangement. It means that your morphologic left ventricle is on the right side and morphologic right ventricle is on the left side. So in other words, isolated ventricular inversion. So when you have that situation, the ventricle's in the wrong positions, the conduction system for the atrioventricular conduction system rather is in a totally different position compared to a normal heart. Instead of running a posterior course, it runs anteriorly. So let's say you have a ventricular septal defect in that heart with corrected transposition, congenitally corrected transposition. You would then have an anteriorly situated atrioventricular node, nowhere related to the triangle cock. So forget about triangle cock. It will be anteriorly located, quite close to the os of the right atrial appendage. And then the atrioventricular bundle will be elongated when you have a VSD. It will be related to the anterior border of that ventricular septal defect and not to the posterior border. So that's important to bear in mind if you're going to be patching that ventricular septal defect. It's a long bundle. It courses down and then it branches, of course, to a left bundle branch on the right side and right bundle branch on the left side. However, if the atrial chambers are in the wrong arrangement, that is to say, you have a morphologic left atrium on the right side, receiving the pulmonary veins, and your morphologic right atrium on the left side, receiving the systemic veins, systemic caval veins, then you have the ventricles in the correct position as in a normal heart. The right side of ventricle would be a morphologic right ventricle, left side of ventricle would be a morphologic left ventricle. So in that scenario, you would have the usual arrangement of the atrioventricular conduction bundle as you expect, say in heart with isolated ventricular septal defect, for instance.
Thank you, Professor Ho. And the next question I think I could be answered. Could we use cardiac MRI instead of the echo to evaluate the post-repaired transposition great artery patient? If echo view is optimal, or using transesophageal echocardiography for following up? I think the main answer is possible to find in the last guideline published from the American Society of Echocardiography, especially for using the multimodality imaging in the patient with the transposition of the great arteries. Actually, the cardiac MRI is possible to using, it played the major role as the gold standard for the evaluation of the patient when transposition of the great arteries. We can use them primarily to image the patient after the surgical intervention, also to provide more information regarding this possibility for the performance and the visualization of the viability, and also for the quantification, analysis, assessment of the valvular function and accurate evaluation of the baffles, conduits, and extracardiac structures, which the branch pulmonary arteries, also in the aortic arch. Also, the transesophageal echo in adults with the repaired TGA, we can't use it in those of kind of the patient. We could have the poor window from the transthoracic echocardiography. Also, during the intraoperative imaging, actually in the patient with arrhythmias who needed to have the required cardioversion about this arrhythmia. So the mainly echocardiography and MRI is the main imaging modalities that could give us the answer about the reproducibility of anatomical and hemodynamical information of that type of the group of the patient. The other question is, can we give tips on optimizing echo and assessing the coronaries in a patient with the TGA? I think this is actually one of the possibilities to analyze the anomalies of the arteries in that population. Then we reduce the velocity of the color Dopplers, and then we going to 3 o'clock for analyzing the left coronary artery, and 1 o'clock for the right coronary artery. This is, I think, it was written from the last guidelines from the Professor Meryl Coyne. So, Professor Ho, do you want something to comment about this?
No, I think you covered it very nicely.
Okay. I don't see any other questions, but we could actually go to the further in the next session. So we continue with one of the symposium, which is supported from the pharmaceutical industry. This is the pharmaceutical company Teva, and it's my pleasure to introduce Professor Ivan Goev, and he will speak about the heart failure in patients with the adult congenital heart disease.
Добър ден, колеги! За мен е удоволствие да участвам в този научен форум по образна диагностика в кардиологията. Благодаря на доцент Христова за поканата, на организаторите от международни прояви за организацията, разбира се, и на Тева за това, че подкрепи настоящия симпозиум, настоящата презентация. Моята тема е лечение на сърдечната недостатъчност при пациенти с вродени сърдечни заболявания. Трябва да кажа, че както повечето кардиолози за възрастни, един от така притеснителните раздели в кардиологията при изпит за специалност по кардиология бяха вродените сърдечни заболявания, защото малко или много това е една територия, на която ние кардиолозите за възрастни не се чувстваме комфортно. Но всъщност практиката и развитието и на детската, и на общата кардиология през годините, и на кардиохирургията, разбира се, и интервенционалните процедури доведе до това, че все повече пациенти с вродени сърдечни съдови заболявания доживяват до зряла възраст и всъщност те стават обект на просветяване от страна на нас, кардиолозите за възрастни. Така че щем не щем, ние трябва да се движим в крак с практиката и с науката и да обогатяваме нашите знания за лечението и за грижите за тези пациенти, а те наистина са едни трудни и комплексни казуси, които изискват по-задълбочени познания и много често интердисциплинарен подход. Сърдечната недостатъчност при тези пациенти в крайна сметка е едно сравнително често срещано състояние с оглед на това, че продължителността на живота им се удължи значимо. И за това, както ще видите в хода на моята презентация, Европейската кардиологична дружество и American Heart Association са направили едни специални консенсусни документи за лечение на сърдечна недостатъчност при пациенти, възрастни пациенти с вродени сърдечни пороци. Така че, ето, това е европейски консенсусен документ, как изглежда. И всъщност едно от основните неща, които той ни казва е, че през 60-те години само 15% от децата с вродени сърдечни заболявания са доживявали до зряла възраст, докато в момента над 85% от тези пациенти доживяват до зряла възраст и това означава над 1 милион такива пациенти в Северна Америка и над 1,2 милиона в Европа. Тоест това е една наистина значима популация от пациенти. Разбира се, както казах, в хода на техния живот и на развитието на тяхното заболяване около 20% от тях стигат до хоспитализации по повод на сърдечна недостатъчност. Така че проблемът е наистина сериозен и популацията е немалка. Виждаме тук една графика, едно сравнение от 80-те години, от 85-та до 2000-та, как нараства броя на пациентите с вродени сърдечни заболявания и тяхната преживяемост, включително и на тези с тежките състояния, които в миналото са били буквално несъвместими с живота. Така че наистина благодарение на напредъка на детската кардиология, на кардиохирургията и на интервенционалните процедури, все повече такива пациенти достигат до нас. Много класификации са предложени. Разбира се, най-важното е, че имат тези аномалии се разделят на такива с голяма сложност и комплексност, които, например, Ейзенмегер синдром или атрезията, някои от клапите, или с умерена такава комплексност, каквито са атеровентрикуларните фистоли, например, или коактацията на аортата или аномалията на Епщайн. По-прости, които са, да кажем, коортните стенози и разбира се, това са пациентите с коригирани дефекти. Така че най-различна и богата гама от пациенти попадат при нас и съответно и поведението ни и оценката им, както по отношение на бързата диагностика, така и по отношение на терапията, трябва да бъде съобразено с сложността, с комплексността на тяхната аномалия. По отношение на класификацията, разбира се, имаме американската класификация, която добре познаваме за сърдечна недостатъчност, имаме НИХА класификацията, която е най-използваната при нас. Използва се и канадската класификация за оценка на ангина пекторис и едни по-опростени класификации, които особено в педиатричната популация се използват за оценка на физическия капацитет на пациентите. Така или иначе, основното е да се оцени дали пациентите имат оплаквания и дали тези оплаквания са в покой или при физическо натоварване и при какво физическо натоварване. Съответно, какви натоварвания на физически могат да понесат тези пациенти и разбира се, дали могат да понесат бременност. Това също се обсъжда на различни етапи от оценката на пациентите с вродените аномалии, както по отношение на наследствеността на самата аномалия, така и по отношение на това дали хемодинамиката позволява да се толерира една бременност. Така, различни причини може да има при различните аномалии за развитие на сърдечна недостатъчност. Разбира се, обемното натоварване, особено при шунтовете, е водещо. Тензионното натоварване при коортните и обструктивните болести също. Една собствена миокардна дисфункция първична може да има. Пулмоналната хипертония, първична или вторична, също така трябва да се има предвид. Артериалната хипертония, която се развива в последствие, както и коронарната болест, която би могла да бъде функция на вродените синдроми или би могла да се развие по-късно в зряла възраст. Разбира се, цианозата и аритмиите също играят роля при развитието на сърдечната недостатъчност. Така че виждаме, че тези многообразни и многолики синдроми водят и до многообразни причини за развитие на сърдечна недостатъчност. Това е едно по-подробно описание на патофизиологията, което показва, че систолната дисфункция може да бъде на морфологична лява камера и да бъде пак основно от обемно натоварване или от повишено налягане, както и от миокардна увреда. Систолната дисфункция обаче също така може да касае и субпулмоналната морфологична дясна камера Също така и една морфологична дясна камера, която е системна, или съответно лява камера, която е разположена под пулмоналната артерия. Така че имаме различни варианти на систолна дисфункция и в крайна сметка много от тях могат да резултират и в левокаменна дисфункция, в тахиаритмии, които могат да бъдат и фатални, за съжаление. Не бива да се пренебрегват и специфичните коморбидности, които имаме при пациентите с вродени сърдечни заболявания. Много често, било поради съчетание аномалии, било поради хроничния чернодробен застой, се развиват бъбречни заболявания. Развива се също протеингубеща ентеропатия, която води до една много сериозна хипопротеинемия и хипоглобулинемия. Особено това е характерно за пациентите с дисфункция след фонтан процедура. Съответно, може да има така наречения пластичен бронхит, който също така е една не толкова честа, но неприятна белодробно усложнение. Също така може да имаме нарушение на бъбречната функция, които могат да бъдат по най-различни причини, но както знаем, те в хода на развитието на сърдечната недостатъчност прогресират. Специфични хематологични състояния също могат да се наблюдават, които могат да са част от синдроми, но могат и да са резултат от, например, хемоконцентрацията при една част от пациентите. Повишените нива на пикочната киселина също така са едни чести нарушения, които могат да са свързани с диуретичната терапия, но също така и с патофизиологията на самите заболявания и понякога се наблюдава и дисфункция на костния мозък и всъщност намален брой на тромбоцити и увеличен риск от кървене. Така че многолики, многообразни коморбидности, някои от тях свързани с сърдечното заболяване, други свързани с някои синдроми, се наблюдават и също трябва да се има предвид при третирането и при наблюдението на тези болни. Най-честите усложнения какви са? Камерната дисфункция, било то на лявата или на дясната камера, както казахме, аритмиите, за съжаление, доста чести, много често фатални, тромбози при фонтан, реконструкциите, отново виждаме протеингубещата ентеропатия, дисфункция на клапите, било те нативно увредени или реконструирани, резидуални ляво-десни шънтове, обструкция на входящия или изходящия тракт на камерите, повишено системно съпротивление, както и повишено белодробно съпротивление. Така че множество патофизиологични механизми и множество усложнения и коморбидности имаме при развитието на сърдечна недостатъчност при пациенти с вродени сърдечни заболявания. И как всъщност проследяваме тези пациенти? Разбира се, образната диагностика има водещо значение, третирането на коморбидностите също. Ако образната диагностика установи някаква сигнификантна хемодинамична лезия, трябва да се мисли за структурна корекция и поправка според гайдлайните. Ако лезията е преценена като не толкова значима, трябва да се прецени функцията на камерите. Дали имаме нормална камерна функция или увредена такава. Ако имаме нормална, общо взето пациентите вървят с проследяване. Ако имаме нормална функция, но пациентите имат някакви симптоми, трябва да бъдат изследвани както с натиоретични пептиди, така и с теста с натоварване, по-добре кардиопулмонален тест. И според техните резултати, ако има повишаване на натиоретичните пептиди или намаляване на съответно на физически капацитет и кислородната консумация, да се мисли за съответното специфично лечение. Ако имаме увредена систолна функция, било на системна дясна или на системна лява камера, отново се преценява пациента симптомен или асимптомен и съответно симптомните пациенти директно преминават на лечение, а симптомите се оценяват отново с натиоретични пептиди и кардиопулмонален тест. Тоест има една стъпаловидна каскадна оценка, която включва, разбира се, подробна анамнеза, образни методики и при необходимост изследване на биомаркери и тестове с натоварване, за да се стигне до правилното и навременно поведение при нашите пациенти с развита сърдечна недостатъчност на фона на вродени сърдечни пороци. Така, каква би трябвало да бъде терапията? Ако имаме морфологична лява камера с понижена фракция под 40, независимо от това дали са симптомни или асимптомни пациентите, имаме класическата терапия за сърдечна недостатъчност, базирана на RAS-блокери, бета-блокери, мидералкортикоидни антагонисти, диуретици и диоксин. Диоксина по-често присъства, ще забележим в схемите за вродените пороци. Когато имаме морфологична дясна камера с понижена фракция, забележете, ако пациентите са асимптомни, можем да ги оставим без терапия. При тези, които са симптомни, вече отново класическата схема, базирана на RAS-блокери, бета-блокери, мидералкортикоидни антагонисти, диуретици и диоксин. Така, субпулмоналната камера, ако е с морфологията налява или надясна, такава и с фракция под 40, т.е. това е камерата, която осигурява пулмоналното кръвообращение. Отново, ако са асимптомни, тези пациенти не подлежат на лечение. Ако са симптомни, забележете, лечението е на практика диуретици, като това са бринкови или тиазидни, мидералкортикоидните антагонисти и пулмонални вазодилататори за намаляване на пулмоналното налягане. Тоест, когато дясното сърце, независимо дали то е морфологично дясно или морфологично ляво е обременено, терапевтичният подход се базира на диуретици и пулмонални вазодилататори. Ако имаме случаите на обща камера с фракция под 40 и фонтанна циркулация или с морфологията на лява камера, дори и при асимптомните пациенти се прилага терапия като за сърдечна недостатъчност, защото един хемодинамичен провал на една такава камера е фатален. Ако имаме морфологично дясна камера, съответно асимптомните пациенти не се третират медикаментозно, морфологичната лява или дясна с симптоми се третират по класическата схема със сърдечна недостатъчност. Когато имаме персистиращи ляво-десни шантове, асимптомните пациенти отново могат само да се наблюдават, а симптомите се третират с диуретици и медикаменти, редуциращи след натоварването. Сърдечната недостатъчност е запазена фракция. Този проблем, както в конвенционалната кардиология, така и при пациентите с вродени заболявания, е един сложен проблем. Тук препоръката е асимптомите да не се третират, а симптомите да се третират с диуретици, евентуално с бета-блокери и калциеви антагонисти, които контролират сърдечната честота. Знаем, че в тази популация терапевтичните алгоритми все още са в процес на проучване и на установяване. Какво казват американците по повод на терапията? Тук прилагат тяхната класификация за стейджа, когато всъщност това са пациенти в риск от развитие на сърдечна недостатъчност, но все още асимптомни. При тях просто трябва да се идентифицират рисковите фактори, по възможност да се контролират, за да не се стигне до прояви на сърдечна недостатъчност. В стадии Б вече имаме структурно сърдечно заболяване без ясни симптоми на сърдечна недостатъчност. Тук вече при селектирани пациенти трябва да се започнат RAS-блокери и бета-блокери, за да се забави прогресията към стадий С, когато вече е симптомната сърдечна недостатъчност и когато вече се налага приложението на диуретици за редукция на, разбира се, на обемната задръжка, АЦ-инхибитори, бета-блокери и при определени пациенти добавяне на алцестеронови антагонисти, дигиталис и прилагане на CRT или на асистиращи девайси. И в стадии Д вече това е рефрактерната сърдечна недостатъчност, когато се мисли за сърдечна трансплантация и за палиативни грижи. Така че американската класификация разглежда още пациентите в риск като обект на наблюдение на терапевтични намеси през тези, които имат структурно заболяване, но все още не са развили симптоми до изразените симптоми и крайния стадий на заболяването. Всички те получават съответната оценка, грижи и терапия. Разбира се, отбелязано е, че където може и когато трябва да се правят и хирургични интервенционални корекции, замества се желязото при железен дефицит и се провеждат и рехабилитационни промени с програми за подобряване на физическия капацитет. Когато има пулмонална хипертония, съответно се използват съответните медикаменти за облегчаване на пулмоналното кръвообращение. Отново стигаме до пациентите с запазена фракция. Разбира се, нямаме много стриктни указания, но диуретиците се използват за повлияване на симптомите, а бета-блокерите за увеличаване на напълнението на камерите, така че това са общо взето единствените медикаменти, за които имаме убедителни данни, че и при тази популация трябва да се използват. Сега, този много сложна таблица показва, че всъщност почти всички вродени сърдечни заболявания в крайна сметка водят до някакъв вид тахибрадиаритми. Така че важно е тези тахибрадиаритми да бъдат идентифицирани, да се види те на първо място дали са животозастрашаващи, на второ място да се види доколко допринасят симптоматиката и влошаване на сърдечната недостатъчност на нашите пациенти и при необходимост, разбира се, да бъдат третирани. Така. Всъщност, пациентите, които са с комплексни заболявания, при тях оценката трябва да бъде най-прецизна и на време да се открият аритмите и риска от внезапна сърдечна смърт. Катетерна аблация или имплантация на ICD съответно се предлага на пациенти с рекурентни мономорфни вентрикулни тахикардии и тези, които, разбира се, са преживели кардиак арест. Така че имплантацията на ICD виждаме, че при тези пациенти с преживян арест и с симптомни и продължителни каменни тахикардии са наистина с клас 1, макар и ниво на доказателственост С. Трябва да се обсъди ICD с пациенти, които имаме ниска фракция и под 35, независимо от оптималната терапия за повече от 3 месеца. И особено при тези, при които имаме необясними синкопи и регистриране на камерни тахикардии. Съответно, при брадиаритмите, естествено, лечението е пейсмейкър, като особено брадитахи синдромите, както виждаме, са така една от индикациите на избор, особено когато не може да се осъществи аблация с добър терапевтичен резултат, защото тогава на фона на пейсмейкъра може да се използва и оптимална медикаментозна терапия за третиране на тахиаритмите. Тук нивото на доказателственост е 2, а все пак малко по-малко. Стана дума, разбира се, че пулмоналната хипертония е едно от тежките и усложнения и компоненти на голяма част от вродените сърдечни заболявания. Разбира се, дефинира се като средно налягане над 20 мм и се дели на прекапилярна, изолирана посткапилярна или комбинирана с съответните критерии за това. Много важно уточнение е, че при пациентите, при които имаме вродено сърдечно заболяване и потвърдена прекапилярна пулмонална хипертония, трябва да се съветват да не забременяват, защото при тях риска от компликации по време на бременността и раждането е изключително висок. Разбира се, при всички пациенти с пулмонална хипертония трябва да се направи рискова оценка и трябва съответно желателно и инвазивно да бъдат оценени с диафракапитализация, за да се определи точно типа на пулмоналната хипертония, както и, разбира се, да се определи физическия капацитет, което също има значение. Това е един обобщаващ слайд, който показва, че всъщност много фактори, сред които нервохормоналната активация, предишната хирургия-резидуалните лезии, които остават клапната болест, шънтовете и ендотелната дисфункция, в крайна сметка водят до развитие на аритмии, до миокардни, перикардни заболявания, обемно интензионно натоварване, коронарни симптоми и в крайна сметка водят до вентрикулна дисфункция и хронотопна и компетентност на камерите на сърцето и това в крайна сметка води до намаляване на физическия капацитет, за което допринасят, разбира се, и коморбидностите, свързани с белия дроб, с скелетната мускулатура и нейната детренираност и анемията. Така че сложен е комплексна оценката на физическия капацитет на тези пациенти и всъщност комплексен трябва да бъде и подхода към тяхното третиране с корекция на, когато е възможно, структурните аномалии, с оптимална медикаментозна терапия, когато е необходимо и с приложение на девайси, разбира се, и с оптимална програма за рехабилитация, която много допринася за подобряване и на прогнозата и на качеството на живот, както виждаме в следващия слайд. Важно е да бъде оценявано качеството на живот. Добре е това, разбира се, да бъде с стандартизирани въпросници и съответно пациентите, съобразно с техния капацитет, с функционалния им клас и с риска от възникване на аритмии и внезапна сърдечна смърт, да бъдат съветвани да участват в програми за рехабилитация с цел подобряване на физическия капацитет и подобряване на качеството на живот. Разбира се, терминалните стадии са свързани с насочване за трансплантация и бриджинга моста към това са асистиращите девайси. Трябва да се каже, че насочването към трансплантация е желателно да премине също през кардиопулмонален тест и оценка на кислородната консумация на пациентите. Много нерешени въпроси има при пациентите все още с вродените заболявания и сърдечна недостатъчност. Много въпросителни, както виждаме от този слайд, които трябва да бъдат уточнявани както по отношение на стратификацията на риска, така и по отношение на терапията на асимптомните пациенти, така и по създаването на специални скорове за тази популация, за ролята на биомаркерите, за ролята на параметрите от кардиопулмоналните тестове, както и параметрите от образните диагностики, за да се изгради единна скринингова стратегия и да могат наистина на време и оптимално да бъдат използвани всички методики, включително и асистиращите девайси и CRT, за да се удължи живота и то да се удължи комфортния и качествения живот на тези пациенти и да се предотвратят случаите на внезапна сърдечна смърт, което също така е много важно. Стана дума за това, че все пак трябва да се обсъждат и бременности при младите пациентки с вродени сърдечни заболявания. Споменахме, че има индикации, които категорично са контраиндикации за забраняване и то не толкова поради унаследяването на заболяването, колкото поради хемодинамичния риск по време на бременност за самата бременна жена и виждаме общо взето в какви проценти някои от най-популярните вродени сърдечни заболявания се унаследяват при мъже и при жени. Все пак процентите не са толкова високи, но такава зависимост съществува и тя трябва да се дискутира с пациентките и с техните партньори. Какво трябва при пациентите, особено с цианотичните пороци, да се внимава и да се избягва, за да не се акцелерират симптомите и проявите на сърдечната недостатъчност? Стана дума за железния дефицит, който трябва да се коригира, да се внимава с неподходящата или предозираната антикоагулация, защото това води до риск от сериозно кървене и допълнително анемизиране. Дехидратацията също трябва да се избягва, защото също води до влошаване на симптоматиката. Инфекциите, всички инфекции знаем, че крият в крайна сметка рискове от развитие на инфекциозен ендокардит или миокардит. Затова се съветват пациентите да се вакцинират срещу грип и срещу пневмококови пневмонии в сегашната ситуация, разбира се, и срещу коронавирус. Да се избягва пушенето, да се избягват инфекциите разбира се, на пейсмейкерите, отвеждания, прекалено големите и резки натоварвания, както и излагането на екстремни термични шокиращи преживявания, каквито са сауната, например, или прекалено студеното време, да кажем, с упражняване на зимни спортове, да се избягват по отношение на превенцията на бременността, да се избягват естроген съдържащите контрацептиви, защото те увеличават риска от тромбози. Така че множество допълнителни фактори трябва да се имат предвид, за да се менажира състоянието на тези пациенти през годините. И в заключение трябва да кажем, че вродените сърдечни заболявания вече не са детски болести. Голяма част от тези пациенти, благодарение на напредъка на медицинската наука и най-вече на детската кардиология и на инвазивните процедури и на кардиохирургията, тези пациенти доживяват до зряла и до напреднала възраст. Разбира се, това означава един преход от детските кардиолози към кардиолозите за възрастни с подходящото проследяване на техните симптоми, с подходящата продължителна практика до животна медикаментозна терапия, която да препятства развитието на сърдечна недостатъчност, също така и развитието на кардиоемболични инциденти, инсулт, развитието на инфекциозен ертокардит, на аритмии и на коронарни синдроми. Естествено, трябва да се обърне внимание на това, което стана дума по отношение на бременност и на съвети за проследяване на бременността или на избягване на такава, когато тя носи големи рискове, както за майката, така и за плода. Благодаря ви за вниманието и пожелавам успех на този изключително интересен научен форум.
Благодаря на професор Груев за възможността да изнесе тази интересна лекция, тъй като темата за сърдечна недостатъчност наистина не сме я засегнали при вродените пороци при възрасти, но и там този обзор наистина дава една такава добра картина по отношение на всички заболявания, които са на дневен ред по отношение на прогнозирането и отправянето на прогнозата при пациентите с вродени заболявания. Професор Горе, виждам, че сте на линия. Аз бих искала да ви попитам какво бихте препоръчали, тъй като тези пациенти тепърва ще нарастват като бройка и ние значително по-често ще се срещаме с тях в реалната практика, защото все повече деца, които са оперирани, минават възраст над 18 години и те се загубят някъде в пространството. Но оценката на риска от развитие на сърдечна недостатъчност остава голям и не е напълно осъзнато това какво се случва с тази популация от пациенти. Хемодинамиката, която се наблюдава при тях след оперативно, е в зависимост от това какъв тип сърдечен порок ще имаме, цинотичен или ацинотичен. Също така дали имаме еднокамерно сърце или имаме една вродена коригирана транспозиция. Всичко това изисква един по-друг подход за оценка на изявата на сърдечна недостатъчност. Какво бихте препоръчали да се направи? Може би тук е и време дружеството по кардиология или пък на асоциацията ни по ехокардиография и по образна диагностика да се намеси и да се създаде един национален план в проследяването на тези пациенти, така както се прави и в другите страни. Имам предвид това, което е въведено в Съединените щати, в Англия, Франция, в другите европейски държави. Все пак стръгването от един регистър и наблюдението на тези пациенти в едни водещи центрове, може би ще бъде, така да се каже, възможността да си подадем ръка и да не изоставим тази група, тази популация да бъде извън в пространството, извън обсека на здравните грижи.
Не мога да бъда по-съгласен с това, което казахте, доцент Христова. Абсолютно необходимо е да се създадат специализирани центрове по подобие, може би, на това, което се получи с пулмоналната хипертония. Знаем, че там това до голяма степен е обвързано с протоколите за лекарство, но така или иначе там се получи така, че тези пациенти да се концентрират и да се проследяват в специализирани центрове. Всъщност пулмоналната хипертония е само един от аспектите на вродените сърдечни заболявания и на развиващите се след това сърдечна недостатъчност. Така че за тези пациенти абсолютно необходимо да се оформят такива центрове за проследяване на възрастните пациенти с вродени сърдечни пороци. Там да има интердисциплинарен подход, т.е. да се получи, да има на разположение като консултант детски кардиолог, който много често е по-добре запознат и с хемодинамиката и с корекциите, които са направени от пациентите, съответно самите кардиолози за възрастни, които са там, да са по-добре обучени и по-запознати с патологията и разбира се да имат на разположение най-съвременните образни и функционални тестове, за да могат да оценят на време състоянието и рано да уловят симптомите на развитие на сърдечна недостатъчност и на аритми и на всичките животозастрашаващи усложнения при тези пациенти. Така че най-важната стъпка е създаване на такива центрове, структурирането им и насочването на пациентите към тях. И втората важна стъпка, разбира се, това, което правите и в момента, за което наистина отново изказвам моите адмирации. Една просветителска дейност сред всички нас, които сме кардиолози конвенционални, да се разширява нашия поглед, да виждаме, че тези пациенти може би не изглеждат сложни като хемодинамика и като морфология, която виждаме с образните методики, но те не са малко, те са реални и ние сме длъжни да отговорим на техните потребности, защото тези хора, слава Богу, виждаме над 80% преживяват и достигат до зряла възраст. Така че ние сме длъжници към тези пациенти, към техните семейства и трябва да направим всичко възможно те да получат адекватна и специализирана грижа.
Благодаря. Да, наистина това ще бъде и проблем за напред. Това, което ние се опитваме да го правим, ще го правим по отношение на обучението на кардиолозите. Аз наистина благодаря на Royal Brompton Hospital в лицето на професор Вайли и професор Хо, които наистина се съгласиха да изнесат този курс, който при тях е традиция всяка година и се провежда на живо, включително с практическа възможност. И се надявам, че ние ще продължим в тази насока, дори в по-малки групи, за да обучаваме нашите колеги, които имат интерес именно към вродените пороци при възрастни. И един друг въпрос, понеже ти обичаш кардиопулмоналните стрес тестове и се доста така напред с тях, бих искал да те попитам, в коя група от пациенти с вродени пороци при възрастни би предложил оценката на риска от развитие на сърдечна недостатъчност да се приложи кардиопулмонален стрес тест?
Разбира се, в един идеален свят бих го предложил на всички, защото кардиопулмоналният тест, това е най-близко до пълната функционална оценка за нашите пациенти и не само тези с вродените пороци. Важно е да кажем обаче, че когато имаме затруднения в диференциалната диагноза на задуха, например, тогава може много да помогне кардиопулмоналният тест от една страна. От друга страна, пациентите, които желаят по-активно да се натоварват, ние трябва да им дадем една основа, върху която да стъпят и върху това да изградим рехабилитацията, защото имаме много прецизна възможност за оформяне на тренировъчни зони и постепенно увеличаване на натоварването. И от трета страна, разбира се, пациентите, които вървят наистина зле и са кандидати за трансплантация. Мисля, че няма развит център в света, който се занимава с трансплантация, който да не използва кардиопулмоналния тест за оценка на кислородната консумация и улавяне на момента, когато всъщност пациента вече е стигнал до асистинг девайс за трансплантация. Така че, пак казвам, в идеалния свят аз на всички пациенти бих предложил този тест, но има определени групи, при които ползите са още по-големи.
Да, наистина това е една от възможностите, която ние можем да решим. Дали пациентът ни е с сърдечна или с дихателна сърдечна недостатъчност. И нека никога не забравяме тези възможности, където можем да го направим при тия пациенти, да не си спестяваме възможността да получим една по-пълна диагностика. Благодаря на професор Груев. Не виждам въпроси в чата в момента, но смятам, че бяхме достатъчно изчерпателни. Предполагам, че ще останете и за по-нататък в дискусиите, професор Груев. Чувствайте се поканен.
Благодаря много.
Да. Благодаря много и на фирма Тева наистина за оказаната възможност и за спонсорството, което направиха за тази среща, за да бъде осъществена. Благодаря ви, колеги, и наистина за сътрудничеството. So we'll continue now with the second part of this morning session. The next topic will be the morphology of the left ventricle inflow tract and outflow tract lesions. It's my pleasure to invite Professor Yan Ho. She will starting with the morphology of this type of the population with the congenital heart disease. Professor Ho?
Hello. In this session, I'm going to talk about left ventricular inflow and outflows, describing primarily the morphology of obstructive lesions. So to start with, we go even further upstream. And in this situation, we're seeing a partitioning in the region of the left atrium, which reduces or restricts flow to the left ventricle. So we have this portion here, the pulmonary venous left atrium, and we have a membrane or shell in between this and the left atrial outlet that's feeding into the mitral valve. So diagrammatically, this is the situation we are looking at. There's lots and lots of variations. And indeed, in this diagram, I have shown you a variation whereby the shell is more tilted, it's right underneath the fossa ovale. So if there's a secondum atrial septal defect, for example, flow comes through here, through the and down there. Whereas in this particular arrangement, the defect, the atrial septal defect, would be beneath the membrane and feed directly into the left ventricle. This is an adult heart that had been transplanted. And this is an explant heart, rather. We're looking down the left atrium, we see this membrane, and the still image shows you a slightly less impressive membrane. And this is the configuration. This is a membrane to be distinguished from a core triatriatum kind of situation, because this membrane is just sitting right on top of the mitral valve leaflets. Now moving to the valves themselves, the mitral valve can have two orifices, as in this example, one here and the other one here, because I've cut through this orifice to open the ventricular wall. And we see here two orifices in the mitral valve. The mitral valve may have leaflet dysplasia, as we see here, causing stenosis. And in this example, there's loss of intercaudal spaces and even commissural fusion, restricting very much the inflow into the left ventricle. And the third panel here, we see an elongated leaflet, more or less like a kind of veil-like configuration with diminished intercaudal spaces plus commissural fusion. You may see cases with dysplasia, with no course at all. Take it one step further, you get this sort of configuration where there are no course at all, and instead the leading edge of the mitral leaflet is muscular and sort of like joining together of the two pepper muscles, forming a mitral arcade lesion. Again, severely stenotic situation. Then this is the parachute form. Can take two variants, one where you have a single or fusion of the pepper muscles, the other where you have one dominant pepper muscle and the other pepper muscle is very, very small. In this specimen here, we have one in which the pepper muscles are fused together. So we have one, essentially one pepper muscle, a kind of parachute configuration. And take that obstruction for one stage further, you may have one of these situations where there's no mitral orifice at all. There's just a valvular membrane interposing between left atrium and left ventricle. This is the same heart. We see one solitary pepper muscle. Now, when you come to outflow tract obstruction, there are various levels to look out for. Where exactly is this obstruction? May have subvalvular situation or valvular, supravalvular, and coarctation even. So we start off with the subvalvular level. We have anomalous insertions or septal hypertrophy and so on. In this example, we see a ridge here on the septal side. And in this heart, we see the ridge extending like a diaphragm all round, so circumferential ridge or diaphragm. And this is an excision, surgical excision, showing the composition of fibroelastic tissues making up this membrane. Further subvalvular obstructive lesions, such as this one, a septal bulge, or in this case, caudal insertions directly across to the ventricular septum, whereas you know the mitral valve normally does not have caudal insertions to the septum. And this is an example associated with a ventricular septal defect with malalignment into the left ventricle. So you see, look up to the outflow tract, you see the outlet septum deviated into the left ventricle, very severely obstructing the outflow tract to the aortic valve. And the longitudinal cut shows you just how obstructed this outflow tract is. Moving on then to the valvar level, just to do with the aortic valve. Then you can have 3 leaflets, 2 leaflets, 1 leaflet, and so on. And these are examples of those with 3 leaflets, disproportionate in this case, are 2 small with 1 big. This one, the leaflets are proportional, but very, very mucoid in appearance and thickened. The lower panel is acquired age-related calcific aortic calcification. So we see lumps of calcium and very, very tightly stenotic. And in histology, you see the calcification. Coming to the bifoliate or bicuspid aortic valve, this diagram way back in 1961 by Edwards shows you quite nicely that you have unequal sizes of leaflets tend to be stenotic, and usually equal sizes can also give you stenosis. The unequal and redundant were deemed to be non-stenotic. So some examples of bicuspid aortic valve. It's not that uncommon, occurring in 1 to 2% of the population. There are basically two arrangements of the valvar leaflets, one to the other. The anterior-posterior arrangement is much more common. So the 2 coronary arteries arise from a more anteriorly situated sinus. It's usually a kind of ridge raphe between in the anterior leaflet. Becomes stenotic early on in people, then in those with tricuspid kind of aortic valve arrangement. And we see here some very severe examples of calcific stenosis of aortic valves. But the lower panel shows you heart specimen from a teenager who had a stenotic aortic valve, but that's due to dysplasia of the valvar leaflets rather than calcification. Moving on to the unicuspid and unicommissural arrangements, then we have some examples here, tend to be very young infants that we come across these. And much less frequently is this sort of dome-shaped arrangement. There's an attempt to form 3 separate valve leaflets, but not quite successfully. So we have this kind of configuration instead. Then moving further upstream, we have the supravalvi and then followed by the coarctation lesions. So what do we mean by supravalvar obstructive lesions? There are 3 forms basically: the hourglass form, the diaphragm form, and the diffuse hyperplasia form. This is an example of an hourglass configuration where the stenosis at the sinutubular junction. See how there's a kind of waist arrangement and deep sinuses and deep pocket-like arrangement of the valvar leaflets. And over here, we see isolation of the coronary artery in the sense that the leaflet has come up and fused across to the sinutubular junction, isolating this coronary orifice. And here's a still picture of it, showing you just this waist-like arrangement. Then we have the diaphragm type, which we hardly see at all in the postmortem series. And this is one of the rare examples here, because I think it can be resected quite readily and relieved, opening up the upflow to the aorta. And this is a case with diffuse hyperplasia. So we can see the leaflets are also kind of run deep pockets. But we see the aortic wall is very, very much thickened, almost like macaroni, kind of pasta. See here, very, very much thickened. So diffuse hyperplasia of the aortic wall. So moving to coarctation, it is a discrete narrowing versus tubular hyperplasia, which describes a length of narrowing, usually in the aortic arch. So we see here some examples. In the older individuals, I tend to see a kind of waist-like lesion, whereas in younger individuals, I tend to see a shelf-like configuration of that narrowing or substrate of that narrowing. The location of the coarctation lesion can be preductal, paraductal, or postductal. So this is an adult heart specimen. We see a bit of narrowing there, and we see a dip, a waist lesion. And looking up from the cut descending aorta, looking back up to the isthmus, we see indeed a very, very narrow orifice. In this situation, there's likely to be a well-developed collateral circulation. These are complications which we don't see at all these days, hardly any. These are examples from our museum. Some of them go back to nearly 100 years ago. And we see here some rupture and dissections of the aorta post-coarctation lesion. So then, to summarize, the inflow and outflow obstructive lesions, and outflow, we can talk about the levels of lesions, the substrates, and so on and so forth. Thank you very much. Hello, in this session.
Thank you, Professor Ho, for the very nice introduction on the morphology. And now I would like to continue with the echocardiography part of this session. And it's my pleasure to invite here Professor Miss Kathy West. She will speak about echo assessment of the left ventricle inflow and outflow tract lesions. I would like to introduce Miss Katie West. She is the principal echocardiographer and the leading specialist sonographer on the adult congenital heart disease echocardiography. Miss West, the time is yours.
Good morning, everyone. Welcome back to this session. In this session, we'll run through both LV inflow and outflow lesions. We'll cover this all in the one talk, a little bit different to what was advertised in the program, but we will cover the content all together in one presentation. So when we're talking about LV inflow lesions, we really need to start before the flow even gets to the ventricle. So we can know that there are anomalies of the pulmonary veins. So you might see an anomalous pulmonary vein which drains into the incorrect chamber. And that kind of ties over with some of the atrial septal talks, so I won't cover that in this session. We can have stenosis of the pulmonary veins, and that can either be congenital or it can be associated with multiple ablations, or even we see it sometimes following a lung transplant. Moving through the circulation, one of the common mitral obstructions or LV inflow obstructions is called cor triatriatum. There's the supramitral ring, there's the double orifice mitral valve, and there's also anomalies of the parachute mitral valve. And you've heard about all of these in the previous session with Professor Yin Ho. So we'll run through a couple of these. Collectively, the supramitral ring, which is a supravalvular stenosis. Lesions of the valvular disease and also subvalvular are known as congenital mitral stenosis. So we'll start with cor triatriatum. So cor triatriatum is a fibromuscular septum that divides the left atrium into two, like you can see in the image here. So we get this superior-inferior split or division of the atrium. So why is it called triatriatum? So tri means three, and that's because we essentially have three atrial chambers when that left atrium divides into two. This is how it appears on echo. So in a four-chamber view, we do see this membrane crossing the left atrium. And in the image on the right, we see the colour flow. This is a five-chamber view where we're really investigating the mitral regurgitation as we normally would when we pan through the images. And at this point, the cor triatriatum does not seem to be particularly stenotic. But the lesson here is it's really important to pan all the way through the chamber. So with a little inferior panning, see now we've lost the aortic valve, we can see actually that this is quite turbulent. And when we put a continuous wave Doppler through there, we see that there's a mean gradient of 5 millimeters of mercury. And so this is considerable stenosis, or not insignificant stenosis. Here's another lesion, and this one it's a little bit more severe. We see with the colour flow even that there is a continuous gradient. So this gradient, unlike in the last example, lasts throughout systole and diastole. And we see that represented on the Doppler trace. In this situation, we really need to measure the entire RR cycle. We can see here there's quite significant stenosis with a mean gradient of 9 millimeters of mercury. Now, using 2D images, it can be really difficult to underappreciate the severity. So this is a nice TOE imaging. You see the opening there and you can see the shelf in the left atrium. But these images, the 3D images, really tell the story, I think. You can see that the opening from the superior portion of the left atrium to the lower part of the left atrium is really very small. You could almost planimeter that and assimilate that to a valve area. So we see the shelf there very nicely using 3D imaging. The cor triatriatum, if it's on the left side, it's called cor triatriatum sinister. This is the most common type of lesion. The membrane is always superior to the left atrial appendage, and that's an important anatomical landmark. In situations where there is also an atrioseptal defect, sometimes the backup of pressure will blow off, if you like, or decompress into the right atrium. And so the gradient of the cor triatriatum, or through the left atrium, will be underestimated. So we need to just pay particular attention, like in all things with congenital heart disease, to the coexisting lesions, because they do impact on our assessment. This cor triatriatum can also appear on the right atrium, and in this situation it's referred to as cor triatriatum dexter. Surgical intervention is really the only way to overcome this. It doesn't tend to regrow this membrane, so once it's repaired, this condition is considered to be repaired. Moving on to the supramitral ring. So this is very similar to the cor triatriatum, but the supramitral ring is always inferior or lower than the left atrial appendage, and that's how we differentiate between cor triatriatum and a supramitral ring or membrane. The terms are sort of interchangeable. So similar sequelae, we get that pulmonary venous congestion, backup of pressure into the lungs. The membrane can adhere to the mitral leaflets, and so that can cause further valvular damage. Here's an example in a parasternal long axis view. You see the membrane there nicely, and this one has a mean gradient of 4 millimeters of mercury. So both these conditions with these anomalous membranes do cause obstruction. They're considered to be obstructive lesions. Here we see the four-chamber view, and we can see the shelf. It's very, very close to the mitral valve on the left, and then on the picture on the right, we can see that there is actually a PFO here, and this is decompressing. So you can see there is continuous flow across that PFO in both systole and diastole. So it would be easy to underestimate the forward flow gradient through the membrane and through the mitral valve. Moving now to the double orifice mitral valve, this can be seen in isolation. We see it's best seen in the short axis view where we have these asymmetric orifices. You can see two orifices opening nicely there in the short axis view, and no real consequence in the flow there with the colour. They often are asymmetric, and there's a little bit of a clue sometimes in the parasternal long axis view. So, for example, in the image on the left, you can see that there's quite a reasonable valve opening. The leaflets look a little restricted, but they look okay. But with some slight angulation more sort of anteriorly, we see that the valve orifice looks quite different. When you're panning through the valves and you notice these different orifices, that's sort of the clue to be confirmed in the short axis view. Another clue here we see in the four-chamber on the left, we see that there's a significant MR jet that doesn't seem to be associated with an orifice, and that's just because that orifice is out of plane. So we're seeing the more lateral of the orifices with the inflow, but the MR seems to be arising from the more medial orifice. And then in the two-chamber, or the long axis view that we have on the right there, you can very nicely see there are two inflow jets. So in this particular picture, we've captured both inflows simultaneously in the one plane, and that's always a very nice image to capture if you can get it. Now, 3D can really add to this. So this is a case that we did in our lab, and what the 3D revealed was that there was all this abnormal subvalvular apparatus. There was an accessory papillary muscle, and the chordae were really fused. So it wasn't just the valve leaflets themselves that were involved in this condition. There was a little bit more to it, and there was subvalvular involvement. This patient also had a coarctation and a bicuspid aortic valve, and both of those lesions had been corrected. These are commonly associated defects in this patient population. This also can be associated with atrioventricular septal defects, so they do tend to come in clusters. They can occur independently or in isolation as well. Moving now to the subvalvular apparatus with the parachute mitral valve. When there's a true parachute mitral valve, there is genuinely one single papillary muscle, and that's the definition of a parachute mitral valve. Because we have this single attachment point for the chordae, that restricts its opening. So it's like the valve is tented, if you like. That results in mitral stenosis. There is another condition called the parachute-like valve, and that's when there is these two papillary muscles that were really abnormally close to each other, and that's more commonly what we would see in the adult population. Usually with a single papillary muscle, a true parachute mitral valve, we tend to see those, they tend to present earlier in life in childhood. So for LV inflow assessment, these lesions all give similar symptoms to mitral stenosis, so pulmonary venous congestion, backup of fluid or pressure in the lungs. They're commonly associated with LV outflow lesions. Shown complex is one of the conditions we need to be aware of, and that will present with LV inflow and outflow obstruction. So we're getting obstruction at multiple levels, and that results in these sort of heart failure-like symptoms. So let's get on and talk about LV outflow lesions. We're very familiar with this within our adult cardiology. We see aortic stenosis all the time. So let's talk about some really back to basic concepts in echo and physiology and how we need to apply them when we are considering LV outflow lesions. So the assessment of LV outflow is really primarily assessed through the use of our Doppler gradients. And so we need to apply some really fundamental concepts of both physiology and the technical aspects of echocardiography. Talking about physiological principles, so we know that the stroke volume is really this complex interplay between the preload, the afterload, and contractility. So let's just step back for a second and consider what preload and afterload really are. So preload is kind of a diastolic concept, isn't it? It relates to wall stress, it's a relationship of filling pressures, the end diastolic volume, and the LV wall thickness. So all these mitral inflow lesions, they affect our preload. And then afterload is a little bit more about what happens in systole. It's defined as pressure in the LV wall during ejection, but it's affected by blood pressure or outflow obstruction. So these are the things that elevate the LV afterload. Changing topic a little bit here. Now we go back to the basics of echo. So the fundamentals of Doppler. This is Johann Christian Doppler, who was an astronomist and also a mathematician, and he really wrote this equation called the Doppler shift, which we use in every patient that we scan every time we turn on either the color Doppler, the pulse wave Doppler, or the continuous wave Doppler. So you really come back to the mathematics involved in echocardiography. And the key part of the equation here is cos theta. So cos theta needs to be as close to 0 as we can make it. Our clinical application of this is that the angle of incidence is everything in echo. When we are assessing the aortic valve, which is highlighted in yellow in this image, we need to use multiple imaging windows around the chest to make sure we can get that angle of alignment between the ultrasound beam and the actual flow, which we can't see, as close to zero as possible. So we traditionally take our gradients from the apical views, but we should also take them from suprasternal and from the right parasternal, the right sternal edge views. Sometimes we don't feel confident that we've got the right gradient, and so we can try more off-axis imaging. We can use the right clavicular notch, the left clavicular notch, and sometimes even we need to resort to using subcostal. So we do all of this to ensure that the angle is minimized. Every international guideline talks about use of the non-imaging probe. So you may be familiar with this movie Karate Kid. This is Mr. Miyagi, and Mr. Miyagi teaches Daniel-san that men who catch fly with chopsticks can accomplish anything. And this is really about practice. It's about practice and repetition, and every sonographer or everyone who picks up an echo probe should be able to use the PEDOF probe. So I say sonographer who catch gradient with PEDOF probe can accomplish anything. This is another guy who's really influential in the echo world, and this is Daniel Bernoulli. So what he did was he set the relationship between increasing velocities and pressures falling. So as there is an increased pressure differential across two chambers, there's a very high velocity between them. We apply this all the time in our aortic stenosis patients. The Bernoulli equation is actually quite complex, and in most parts of cardiology, we can ignore lots of these different elements. Convective acceleration, though, is actually really important. And when we're assessing valvular lesions, we are measuring essentially the convective acceleration. So this occurs whenever there is a change in the cross-sectional area of flow. Flow acceleration generally in echo we tend to ignore, and viscous friction only becomes relevant, not so much intracardiac, but if we're talking about things that we see in congenital imaging, like BT shunts, long tubular narrowings, even coarctation, this can come into play. So in general cardiology, we simplify this formula, and whenever that V1 velocity is greater than 1.5, we need to correct our Doppler gradients. Most of the time, though, we can just use this very simple formula of 4V squared on the velocity equals our pressure gradient. But sometimes we do need to step back to this modified Bernoulli equation and account for those elevated pre-stenotic velocities. So LV outflow lesions are way more than just LVOT obstruction. So we can see that, like in the left ventricular inflow, obstruction can occur at any level through the LV outflow, including up into the aorta and around the bend to coarctation. So let's start at the beginning. We'll talk about subvalvular obstruction. And subvalvular obstruction or obstruction in the LVOT can be dynamic, like we see it in HOCM, or it can be fixed with either a ridge or a membrane. And look at the difference in the Doppler shape, in the Doppler signal. This gives you an indication of the anatomy behind the obstruction. So we'll just talk about hypertrophic cardiomyopathy just very, very briefly. This is a patient who we saw who, during the regular echo, had a peak gradient through the outflow tract here of 2 meters per second. We asked the lady to Valsalva, and we were able to get a velocity of 3 and a peak gradient of 38. And then we got the patient to sit up, and we were able to further exacerbate that gradient by getting the patient to sit upright. So what's happening here? Remember that HOCM is a really dynamic lesion, so it's very sensitive to changes in preload. And when the patient is lying on the examination couch in the echo room, the forces of gravity are really evenly distributed throughout the patient because the patient is lying horizontal. But as we get the patient to sit or even to stand, those forces of gravity change and we get venous pooling, and there's more blood in the feet than there is in the upper part of the body. And so it's always wise to capture that gradient not just at rest, but also with Valsalva and with changing the patient positioning. If you can get your patient to stand, that's even better, but not all patients can manage that. So that's how most of our patients experience their symptoms. They spend most of their days upright, and so it makes sense to do that as they make that change in position. Now, moving on to fixed LVOT obstructions, this can either be a membrane or a ridge, which are really the same kind of thing, or a lung tubular tunnel kind of obstruction. These are a very nice case, so we can see the little nubbin on the septum there, but this is more real life, and sometimes this is all you get. So it just pays to really zoom in on these views. Particularly what happens here is the aortic valve leaflets are opening well. They look thin and mobile, but we get a gradient across the outflow tract. But this parasternal view can be really deceiving. So what we see just as this very little membrane or little outreach in the parasternal long axis view, we don't really know the effect of that until we turn to the short axis view. So you see, if we draw a line, we don't really know if we're going to get the top option or the bottom option here. We cannot tell the severity of stenosis just by looking at the parasternal long axis view, which is where we tend to detect it. So this is the same patient that I showed you with the difficult images. We can see there's quite a significant subaortic membrane in this patient. I'll show you now some apical 5-chamber views. You see the membrane on the 2D imaging. You see the turbulence arising in the LV outflow tract. And we also see that there's aortic regurgitation. And that's really common. And it's common because we now have turbulent flow forcing the valve to open. And so there's sort of repetitive injury or collision, if you like, or those blood cells are really accelerating towards the aortic valve, and that causes fibrosis and scarring, and the valve does tend to leak. In this particular case, we got a peak gradient of 43 with a mean gradient of 27, and you can see that the signal looks exactly the same as an aortic stenosis signal. It doesn't look like a HOCM. It's not late peaking. It's early peaking, and we have a valve. The 2D appearance of the valve doesn't correlate with the gradient. So we need to look really closely at the origin of the turbulence on the colour flow imaging. Congenital aortic valve disease, you'll be really familiar with bicuspid aortic valves, but this slide is just to show you that you need to assess the aortic number of leaflets in the aortic valve when the valve is open. So the top line here is diastole when the valve is closed, and the bottom row of images here is in systole. And you can see that there's not that much difference in the appearance between the unicuspid valve on the left and the normal trileaflet valve second from the right. They don't look very different in diastole, so it's really important to assess the number of leaflets when the valve is open in systole. You can see there's a very nice quadricuspid valve in there as well. Now, the natural history of bicuspid aortic valves, I'm sure you're all very well aware of this. We know that these valves do tend to become dysfunctional, either with stenosis or regurgitation. We know that they are subject to infection. We know that they are associated with aortopathies, and we know they can also be associated with syndromes like Turner syndrome or Marfan syndrome, and we do see these in our adult congenital clinics. But isn't such a thing as a simple bicuspid aortic valve? So on the left, we have what we call true bicuspid valves. There is only 2 sinuses and 2 clearly defined leaflets with no raphe. And then we have the functional bicuspid aortic valves on the right, where there's various combinations of fusion of 2 of the leaflets. There's been a lot of work that's gone into this, seeing if we can predict what kind of dysfunction, whether stenosis or regurgitation, based on the anatomy. Quadricuspid aortic valves are quite rare, actually, but we see them all over Twitter, if you're a Twitter fan. So we think they're much more prevalent than they really are. You can't take what you know about bicuspid valves and apply it to quadricuspid valves. They are quite different entities. So aortic stenosis is quite uncommon in a quadricuspid aortic valve. More commonly, you will see regurgitation. They are associated with coronary artery anomalies, and the root dilatation, it's rare, but it is reported. But coarctation is very rare. So the morphology and the pathology that we normally see behind quadricuspid aortic valves is quite different to what we would normally see with our bicuspid aortic valves. So moving on to supravalvular aortic stenosis now, this is an autosomal dominant condition. We usually see it with Williams syndrome, and we see a really nice angiogram here where the supravalvular aortic stenosis is quite striking. Unfortunately, on echo, it doesn't always appear so striking, and it can be really easy to miss. So this patient has supravalvular aortic stenosis, and you might just notice that at the level of the sinotubular junction, it just narrows down a little bit. And sometimes on the 2D findings, it can be very, very subtle. So here's a zoomed in view. Again, even the measurement isn't particularly unusual of 2.3, but I will go ahead and I'll show you the Doppler. So on the apical 4-chamber view, just doing a routine scan, peak gradient of 16, again, very easy to miss, but you need to also employ your clinical suspicions. If there is a murmur, go looking for something, particularly in a patient who has Williams syndrome, and by using the non-imaging probe from the suprasternal notch, so up here in the arch views, we were able to get a peak gradient of 47 and a mean gradient of 21. So, in the realms of moderate aortic stenosis, which could have been actually very easily missed. Supravalvular AS is generally repaired by this aortoplasty. They kind of resect the ridge. They can open up the aorta if necessary, and then they re-anastomose those two segments of the ascending aorta together. Okay, so now we'll move on to aortic coarctation, and this is actually one of my favourite lesions, and the way I like to describe this is thinking about the physiology that happens before the lesion and the physiology that happens after the lesion. So if we consider what happens before the lesion, we have this very tight narrowing and we have a backup of pressure. Now that pressure transpires in multiple ways. So we might notice an elevated blood pressure, we have increased afterload on the heart, and so we might see signs of left ventricular hypertrophy, and we have a buildup of pressure also in the brain, which can predispose patients to cerebral aneurysms. Downstream of the lesion, we have reduced flow, and this is what can cause this particular condition to be really life-threatening. So we could have ischemia to the gut and to the viscera, so multi-organ failure, multi-organ ischemia, which is a life-threatening emergency. We can have claudication, the classic clinical sign, reduced femoral pulses, and we can also have some degree of cyanosis. So coarctation of the aorta can happen in multiple locations up there in the aortic arch, and we usually describe it in children at least in a position relative to the ductus arteriosus. So a pre-ductal coarctation will actually increase the cyanosis because there will be flow from the duct mixing with the blood, so that deoxygenated blood that's coming from the pulmonary artery through the duct into the descending aorta. So you might have a differential cyanosis where the feet are blue. Now, on a preoperative echo, we need to correct those gradients for proximal flow, especially when there is coexisting or concomitant aortic stenosis. So this is when we need to apply that information from the Bernoulli equation, and we might need to correct our V1 velocity. So take, for example, the situation where you've got a patient who has a bicuspid aortic valve with severe stenosis and a coarctation. If there is a velocity of 4 or 5 meters coming up the ascending aorta, it's quite reasonable to expect that there will still be high velocities before the coarctation, so as that flow goes around the bed. So that flow won't normalize just in the proximal descending aorta. So we need to consider that proximal flow prior to the coarctation. We may need to use this modified Bernoulli equation to correct these gradients to ensure that we're not overstating the gradient. This is a classic Doppler signal on what we might see. So if we have a significant stenosis, we see this diastolic flow. So we do see an increase in the velocity, but the key point here is this diastolic continuation of flow. This is classic for coarctation of the aorta. And the reason for this is twofold, I'd say. So one is that there is a continuous diastolic gradient because the narrowing blood the narrowing of the aorta really stops that blood from clearing or passing through the descending aorta. And what that does is it backs up the pressure and backs up the blood flow. And what that does is it extends all these vessels. So all of these normal little intercostal arteries, which carry really minimum volume of blood, start to become a major player and carry a significant amount of volume to get the blood lower down into the descending aorta so that it can feed the organs, the gut. So that's why we get this diastolic flowing of blood. We get all these collateral vessels forming. And here's a really nice example of why it's the diastolic flow that's important and not the aortic, not the peak velocity. So this is a 26-year-old male who presented to accident and emergency with acute onset chest pain a few years ago. He was a medical student, so he insisted on having a CT scan because he had had chest pain. He felt that he had had a pulmonary embolus. It turned out that actually on the CT, it demonstrated an acute aortic dissection. So he was referred to a tertiary centre and he had urgent surgery. This is his intraoperative TOE, so we can see the patient has a bicuspid aortic valve, hugely dilated ascending aorta of 7 centimetres, and he had a type A dissection as well. That was repaired. He had a mechanical aortic valve replacement and a root replacement, and then he had a follow-up MRI scan, which raised the question of coarctation, and so he was sent to our hospital for follow-up. And generally speaking, the valve works well. The intracardiac anatomy here is pretty unremarkable. But then we get to the arch views, and we see this arch reasonably unremarkable, but the colour flow looks a little bit unusual. We're not seeing turbulence. We're not seeing very much at all. And we have this velocity here, so 1.2, totally normal velocity. So that certainly doesn't really fit with the picture of coarctation. When we did the abdominal aorta, though, this is from the subcostal view, what we do see here on both the colour flow imaging and the Doppler spectrum is this diastolic continuation of flow. So it is this flow here that tells the story in this patient. So this suggests there is a collateral circulation. So we need to ask, why is there a collateral circulation in this patient if we don't have any evidence of a coarctation? So this is the patient CT. We can see there is a very, very tight coarctation here and multiple collaterals. There's the narrowing. So you can see that it is incredibly tight, and you can see all of these collateral vessels which have formed, all these intercostal arteries which are really just kind of ballooning out, so to speak, now that they're carrying so much blood flow. The patient went to the cath lab for consideration of stenting, but they couldn't pass the wire retrograde up the descending aorta. So we see the vessels coming into the descending aorta there. They used a coronary wire to open this tiny, tiny narrowing. You can see how severe this coarctation is. They had to come in from the radial approach to get that catheter into the upper part of the descending aorta. And so a stent was put in there, and we had a really nice result from the angio that blew up that narrowing. There's a nice big stent in there now, and so normal flow is restored. Now, this is the pre and the post image. So they're really very impressive, really nice work from our percutaneous, from our interventional team. And here is the CT, both pre and post. And now let's look at the echo, pre and post. So images on the left are the preoperative scan, and post-op you can see the stent here. You can see the stent just protruding into that area in the arch view there. So when we look at the colour on the image on the right actually looks more turbulent than the image on the left. So that's a bit of an unusual finding, and we would not expect that now that that vessel is really opened up. Here are the velocities through that area. So preoperatively, the velocity was there at 1.2 metres per second, and post-op, it's around 2. So we're getting more flow through this area now, but the gradients have gone up. And here is the abdominal aorta, really diastolic continuation of flow with very low velocities in the pre-stent images, and in the post-stent images, we're seeing much higher flow in systole and significantly less flow in diastole. So what's really going on here? Let's go back and look at this preoperative image. Now you've seen the coarctation. You know how tight this descending aorta was. You know how tight this lesion was. So what we really see here is the blue flow is blood coming around the arch, and you see this red flow here. This flow is essentially swirling. It is not passing through the descending aorta. It is coming and swirling and then going up the collaterals and coming down. So the majority of the blood flow is via the collaterals. Let's go back and look at the trace, the Doppler trace. From this arch view, the velocity is really not very high at all. That was not the key indicator here. This is a very extreme case, remember. But look at the diastolic continuation of flow. It is there. And so it's these very subtle signs, these nuances of looking at the Doppler. The abdominal aorta was the clear giveaway with very strong evidence of diastolic flow continuation. So how to repair this lesion? This particular patient was stented, but there are actually a whole lot of surgical options. It's important to be familiar with what they all are, particularly this last one here where there's an ascending to descending bypass. So we may or may not see that on echo, but the important thing in this particular patient is the coarctation will still be there, but because there is no backup of pressure, the flow is all going down through here, so there won't be a gradient. But the native coarctation, the narrowing will be there. It's just that the pressure has been relieved through this extra graft. Here's another example from our lab. This is a 45-year-old male who has had a coarctation repaired many years ago, and he had ongoing hypertension. So we did the echo. This is his, again, the intracardiac anatomy is fairly normal, fairly unremarkable. This is his suprasternal view. And again, we see this diastolic continuation of flow. See that blue flow, it just lingers around, doesn't it? And we also see that on the spectral Doppler. But there's really good flow going through here. So we're not suspicious of a narrowing, but what else could there be? We don't see the same degree of diastolic flow in the abdominal aorta. So this actually is a different situation. We gave this patient contrast, and what it shows, so this is the aortic arch view with contrast, and we see this very big area of contrast here. This is very nicely shown on the CMR. So what we have here is a very large aneurysm at the site of the coarctation repair. And it's just really important to remember this is a common complication post-coarctation repair. We always think about re-narrowing. We know that that can happen, but also remember that the opposite might be true as well. And we can actually get these quite significant aneurysms which need to be addressed. So we need to be careful when assessing LV outflow, particularly when we have serial stenosis. So in the example of a bicuspid aortic valve and a coarctation, remember these modified Bernoulli equations. The issue here is that we can very easily detect the difference between V1 velocity and V2. So we can correct for this situation, but if we add another stenosis in here, we really need to do a V3 minus V2, but we never really know what V2 is. And so when we have serial stenosis, we do tend to overestimate these gradients. And that's really important to keep in mind that the echo data, if the echo data isn't matching up with your clinical intuition, then there could be an error in the gradients. This is irrespective of angle or any of those other things. So it is possible for echo to overestimate the gradients in the case of serial stenosis. And that comes up a lot when we start going back. Remember I mentioned before Schoen complex. So Schoen complex is when we have the inflow lesions, parachute mitral valve, a supramitral ring with outflow lesions of the subaortic membrane and coarctation. So we've got multiple levels of obstruction here, lots of factors affecting the stroke volume and the cardiac output. This is commonly associated with the underdevelopment of the left ventricle and the aorta. It presents with heart failure type symptoms and generally requires intervention of maybe one, maybe more of the lesions. So we need to really try and tease out which is the culprit lesion here. So we need to take care when assessing LV outflow. There are lots of concepts that I have not covered in this presentation. So things like low flow, low gradient and the role of dobutamine stress echo. I haven't talked at all about flow rate. I haven't talked about pressure recovery. And this is important when the ascending aorta is hypoplastic or less than 30 millimeters, any kind of long tubular obstruction. I haven't talked about energy loss, stroke work loss, impedance, or any of these kind of more advanced aortic stenosis type of concepts. They're really nicely outlined in the European guidelines, though. Overall, when we look at LV outflow lesions, our echo assessment requires a really excellent understanding of both the physiological conditions, subjects of preload, afterload, contractility, how are they affecting the measurements that we're getting on echo, and then also the assumptions used in echo physics and maths. Remember, we have to study these concepts when we sit our accreditation exams, but we need to know when to apply them into our clinical practice. So be aware of the shortcomings of the Bernoulli equation, of the Doppler equation. Remember, angle is really important. Remember, we can get into trouble in echo when we have serial stenoses. Each level of obstruction for both inflow and outflow lesions has its own sequelae, so we need to be understanding of what that is. And the echo obviously provides really important information for both patient management and consideration of intervention. Remember, if you're getting gradients and the aortic valve has thin and mobile leaflets, think about those subaortic and supraaortic conditions, which can be really easy to miss. Thanks very much for sticking with me throughout this session. I hope you've learned a trick or two, and that's it for my presentation. Thank you.
Thank you, Ms. West, for very comprehensive and very interesting presentation. I think we could start for a couple of minutes discussion with Professor Ho. Here is also a couple of questions, Professor Ho. I will starting with this, which is more morphological. How do you think it's possible the mitral hurdle attached to the outflow tract will be thus accessory, which can be removed during the cardiac surgery on those of patients with congenital heart disease?
Generally, the ones I've seen are accessory, but I would advise look carefully on a case-by-case basis.
Yeah, this is the most important. There is another one question, I think is from one of our audience from Malaysia, who is very active. How do we differentiate the echo through mitral stenosis from increased flow? I think the main recommendation that for echocardiography, it's very well established for the patient with the mitral stenosis. The typical changes from the echo of the mitral leaflets, it's very important to look at about, but increased flow, it's could be mentioned from the different type of gradient of the late atrium, and we could differentiate also when we look at of the mean gradient. The mean gradient is most important for the differentiates from the increased flow on the mitral stenosis flow, which is dependent from the area of the mitral valve. But I think there is something very interesting that we could also discuss with Professor Ho regarding the adult with postoperative changes in aortic rotation. The aneurysm that we could find is very often, and how we could manage these patients to go mainly for the cardiac surgery is not preferred for the adult with the aortic rotation. The stenting is most initiative that it's preferred from this kind of population regarding the differences of the neurological condition there, and we could send anyway from in the cat lab this kind of population. Did you hear me? Oh.
Well, I'm not really in a position to answer that sort of question, but increasingly the trend is, of course, through transcatheter management of these lesions. It takes really expert hands to do that.
Yes, the transcatheter is this, and then maybe with the follow-up of this kind of patient with the MRI and cardiac MRI is most important to see how it's going for the post-procedural lesion after the cath lab in the near edges. So I think there is no other questions. Any comments from you, Professor Ho?
No, I liked Kathy's presentations, very, very comprehensive and instructive.
Yes, okay. So I would like to continue with the next session from this morning session of our symposium. This will be again symposium of pharmaceutical industry. I would like to invite Professor Paskalev to start for the introduction of the topic of the symposium. Благодаря на фирма Sanofi за възможността да бъдат наши гости и за съпорта, който ни оказаха за тази среща, която независимо, че е онлайн базирана, все пак с доста добро посещение. Над 1200 регистрирани към момента участници от 69 страни. Професор Паскалев, заповядайте.
Много ми е приятно да бъда с вас. Добър ден на всички. Както и да участвам във вашата научна проява Ехокардиографски дни с топика наследствени сърдечни заболявания. Участието ни в вашата проява е с симпозиум, който искам да благодаря за подкрепата на Sanofi Genzyme и който е насочен към една такава наследствена болест, а именно болестта на Фабри. Болестта на Фабри е многоорганно увреждане, включително и сърдечно, което полага един страхотен ефект върху клиничния статус, съответно и преживеността на тези пациенти, поради което сърдечните заболявания, т.е. промени при тези пациенти имат особено голямо значение. Болестта на Фабри е рядка болест с характеристика около и под един случай на 100 000 население. В нашата страна тази популация е сравнително добре проучена, наблюдавана, включително и с кардиолози, което има голямо значение за постигане на по-голяма преживяемост и по-добро качество на живота на тези пациенти. Повече по отношение на тази болест и сърдечните проблеми при тези пациенти ще разбереме от презентацията на професор Кинова. След тази презентация ще имате, колеги, възможности за въпроси, включително и с участието на доцент Христова, тъй като аз съм нефролог и на кардиологичните едва ли бих могъл да отговоря по някакъв начин. Така че, нека да видим презентацията.
Hello, everybody. The topic of Fabry disease is very important because this is a rare genetic disorder which lead to life-threatening cardiovascular or cerebrovascular complications and end-stage renal disease if the diagnosis is missed or delayed. This is an X-linked lysosomal storage disorder with genetic mutation in the galactosidase alpha gene with complete or partial deficiency in the enzyme activity. This is the reason for a progressive accumulation of pathologic substance GL3 in lysosomes of different cells. The clinical expression has a very broad spectrum. Can be detected cardiomyopathy, arrhythmia, central nervous system is involved with cerebrovascular events, obstructive airway disease, gastrointestinal problems, and renal insufficiency. The patients may have corneal and lens opacity, angiokeratoma. Also, what is typical in patients with Fabry disease, this is central white matter hyperintensities, lacunas, and even microbleeds. This is a heterogeneous disorder. There are two phenotypes, classic with early onset. Signs and symptoms starts from childhood with acroparesthesias, pancreatitis, abdominal pain, hypohidrosis. The complications in this form starts in third to fourth decade. The patients may have proteinuria and progression of the renal disease to end stage in the years. Cardiomyopathy develops. Stroke is typical in this early onset phenotype. In these patients, the activity of alpha-galactosidase A is close to zero. There are no enzyme activity at all. These patients have very severe mutation in gene coding this enzyme. Invariant phenotype. Here, patients have late onset of the disease with manifestations from heart or kidney, mainly cardiac or renal variant. The later onset of complications is at 5th to 7th decade. Here we have some residual enzyme activity, and the mutations are less severe. Cardiac impairment is a progressive and early in Fabry disease. The patients may have clinical symptoms and abnormalities which are typical for other cardiac patients. They have congestive heart failure in 25% of cases, chest pain, arrhythmias, syncope, conduction abnormalities. Some of patients may have implanted pacemaker. Some patients may have valve lesions, and what is typical in Fabry disease, this is LV hypertrophy. We should ask very carefully for family history and other reasons for LV hypertrophy. ECG can have some specific changes. This is a short PR interval, and also we may see the voltage criteria for LV hypertrophy. In untreated patients, the morbidity is very severe. There is a progressive accumulation of GL3 in myocytes, valves, and vascular endothelia. And also the metabolite lyso-GL3 stimulates the proliferation of vascular smooth muscle cells and cardiomyocytes. Develops the diastolic dysfunction, systolic dysfunction, arrhythmias, and congestive heart failure with cardiac death. The LV hypertrophy progresses with age. This is results from analysis of the progression of mass in male, which are not treated in Fabry disease registry. In all age groups to age 50 years, the LV mass progresses with time. With 2D echo, we can see LV hypertrophy and also some heterogeneity like in this interventricular septum, and also hyperechogeneity in the posterior wall of left ventricle. This hyperechogeneity may cause by fibrosis, but the method to diagnose and register fibrosis and assess its extent, this is a cardiac MRI. At the beginning, develops interstitial and cell replacement fibrosis, and with progression of the disease, this fibrosis started to extend to all wall of the all thickness of the wall of the left ventricle. Arrhythmias are very common. Up to the age of 45 years, 50% of untreated males reported to have rhythm disturbances, bradycardia, atrial flutter or fibrillation, ventricular arrhythmias. The patients may have conduction impairment. In early stage, this is a short PR interval, and later they can develop AV block. Arrhythmias can occur even in younger age, before age of 10. The major cardiovascular events, myocardial infarction, heart failure, and cardiac-related death in untreated patients account to 5.8% of male and 3.7% of females. The first cardiovascular event occurred at the mean age 45 years in males and 54 years in females. Left ventricular hypertrophy and hypertension were identified as the main risk factors for experiencing life-threatening cardiovascular events at a relatively young age. The analysis of the registries of patients with Fabry disease found that the average age of occurrence of symptoms was 6 years in men and 9 years in women. The diagnosis can often be missed or delayed due to the heterogeneous nature of the disease. The first onset of symptoms to the diagnosis of Fabry disease is approximately 15 years in both men and women. Undiagnosed and untreated Fabry disease can reduce life expectancy by up to 20 years in men and 15 years in women. The prospective observational study with 32 patients with enzyme replacement therapy with the recombinant alpha-galactosidase A enzyme was performed. The patient was treated with recombinant alpha-galactosidase A in dose A with the dose 1 milligram per kilogram intravenously every 2 weeks for 3 years. Patients undergo CMR, echo, Doppler tissue imaging, and bicycle stress test at baseline and also on the first, second, and third year from treatment. The safety profile and severe adverse events was not evaluated in this study, but what the result shows that changes in echo data for hypertrophy showed that in patients with no fibrosis, there was significant reduction of relative wall thickness, septum, and LV mass. In comparison between groups with mild or severe fibrosis and no fibrosis, didn't show statistically significant differences, but relative wall thickness and LV mass reduced in all groups after 3-year treatment. The patients with no fibrosis showed improvement in LV function also, and they improve exercise capacity. In patients with mild or severe fibrosis, there was no improvement in myocardial function and no improvement also in exercise capacity. And the conclusion is that treatment with enzyme replacement therapy should be started before myocardial fibrosis has developed to achieve long-term improvement. Which patients to test for Fabry disease? These are patients with clinical suspicion and unexplained LV hypertrophy, particularly in cases with onset at the age above 40 years, concentric hypertrophy, non-obstructive hypertrophic cardiomyopathy, or patients with proteinuria and renal failure, also patients with bradycardia, chronotropic insufficiencies and specific ECG changes. We, as a cardiologist, should suspect also patients with cryptogenic stroke. These patients were sent from a neurologist to us to assess embolic risk, and we should think about Fabry disease. 0.5 to 3% of cases with idiopathic hypertrophic cardiomyopathy, in fact, are patients with Fabry disease. And this is the most common metabolic disorder we should suspect in our patients with unexplained LV hypertrophy. What can we do? We can perform a test with for plasma and leukocyte alpha galactosidase A activity. The limitation here is that woman can show a pseudo deficit, and that is the reason to perform genetic testing on which the diagnosis can be made. In some cases, because there are multiple variants with non-pathogenic clinical significance, we can use biomarkers, lyso-Gb3 in plasma or urine, and also we can use a biopsy of skin, kidney, or heart. In conclusion, Fabry disease leads to progressive LV hypertrophy, irreversible fibrosis, and heart failure, and also potentially life-threatening arrhythmias. Cardiovascular disease is the most common cause of death. Testing the suspected patients and screening in high-risk populations can identify patients with Fabry disease and start enzyme replacement therapy. Subsequent family screening can identify affected relatives at an earlier stage of the disease. Thank you for your attention.
Микрофона професор Спаскалев.
Благодаря за презентацията на професор Киринова. А сега, ако има въпроси от страна на колеги, които слушат и видяха презентацията.
Аз в момента не виждам, но вие сте един от специалистите в България с най-голям опит по отношение на болест на Фабри и лечението на тези пациенти. Все още нямаме първия кардиологично диагностициран пациент, доколкото знам.
Точно така е, да. Макар че в света първият пациент с болест на Фабри доказан, исторически е точно с кардиачна форма. Тези пациенти са много интересни, защото болестта общо в чисто клиничен аспект води до скъсяване преживеемостта на живота на пациентите при мъжете, чисто клинично като така общ поглед с 20 години, при жените с 10 години. То е благодарение на сърдечните усложнения. Болестта се предизвиква от мутация, която винаги е локализирана в Хикс хромозомата. При жените, които имат две Хикс хромозоми, характеристиката е благоприятна, тъй като има една Хикс хромозома, която противодейства на другата, тъй като е здрава. При мъжете това нещо липсва, заради което клиничната изява и тежестта на промените са по-изразени. В световен мащаб няма описан случай, който да има мутации в едната и в другата хикс хромозома на жените. Но има единични случаи, при които са описани две мутации в една и съща хромозома, включително един такъв случай в нашата страна. В тези случаи най-много се засилва значимостта и проявата от страна на сърдечните увреждания, както и при нашите пациенти, които наши пациенти са жени. Независимо, че са жени, в такъв случай сърдечната патология е много добре изразена, даже много силна, която доста много ни безпокои. Така че тези пациенти са доста сложни с многоорганната характеристика. Те са подложени на стриктно наблюдение и обследване с така една периодичност, която е доста, бих казал, оптимална, включително и по-често, отколкото в някои страни. Възможността за терапията е изключително добра в България, тъй като са налице всички възможни терапевтични характеристики, възможности в нашата страна и ние ги прилагаме. Освен това, лечението се осигурява безплатно по НЗОК, така че тази проблематика също е отпаднала, за разлика от много други страни. Резултатите са много добри. Аз мога да кажа един случай с мъж. Най-често се говори чисто клинично практически, че мъжете рядко преживяват 50-55 години, особено ако не са лекувани. Имаме мъж, който е открит малко преди 50 годишна възраст и сега е някъде близо до 65 годишна възраст, с добра характеристика, разбира се, има съответните увреждания, но това за болен пациент и то с много органна ангажираност увреди, това е доста добър резултат в резултат на терапията, която се осъществява. Всички в България пациенти са абсолютно обхванати с терапия тогава, когато показанията за това, за стартиране на терапията са на лице. Ние имаме около 55 пациенти до 60, които бройка се променят във времето, разбира се, и не малко пациенти, които са зад граница. Така че общо взето имаме една характеристика, която се доближава до средностатистическата, един човек на 100 000 население. Пациентите са много интересни, защото има патология, която е съчетана от всички органи и системи и нещата на комплексна характеристика на участие на различни специалисти е само по себе си много добро и наистина предизвикателство по отношение на тези пациенти, за което аз много се радвам в контакта си с кардиолозите, без които няма как да менажираме тази болест. Но се надявам, че кардиечният пациент с кардиечна форма, която има по-благоприятен ход на протичане, трябва да бъде доказан в България, то с помощта на вас, кардиолозите, и по начина, по който се показва в презентацията на професор Кинов, и надявам се това нещо да стане скоро.
Нека само да повторим, че възможността за анализиране на тези пациенти, за тяхното доказване е напълно безплатно и всичко се поема от фирма Genzyme. Така че, когато колегите имат съмнение за пациент, който е с левокамерна хипертрофия, която изключва наличието на хипертонична болест, на придружаващо клапно заболяване, на друга установена хипертрофична кардиомиопатия, задължително да тестват тези пациенти. Водещата е левокамерната хипертрофия. От тук нататък останалите симптоми, които могат да бъдат засегнати специално от бъбреци, кожа, гастроинтестинален тракт, нервно-мускулна система, са всички останали периферни заболявания, които останалите специалисти гледат от тях. Така че това е по-скоро моят призив към колегите да обърнат внимание на тези пациенти с неуточнена левокамерна хипертрофия. И това, което ние търсим като кардиолози и като ехографисти, именно тези промени, които се наблюдават в задната стена на лявата камера. Това е типичното място за локализация, именно и засягане на промените в лявата камера.
Да, аз се присъединявам към този призив и Винаги казвам така в клинично отношение, практически по-добре те с негативен резултат и за това не трябва да се възпираме от пускане на тестове и при най-малките съмнения, защото в този случай няма да изпуснем пациент. Колкото повече тестове и съмнение, най-малко съмнение, ни водят до необходимостта да пуснем този тест.
Да, и възможността да лекуваме тези пациенти, това е най-важното, защото от засягането на сърцето, независимо, че е по-леко протичането, възможността за развитие на сърдечна недостатъчност, от която нашите пациенти ще загинат с неуточнена причина и без да сме се намесили, е много близък този край, особено когато се касае при пациенти с болест на Фабри, което е неуточнено. Да.
Ами, ако няма въпроси от страна на колегите, които наблюдават и слушат, и
в момента не виждам нищо в чата, не са ми подали да има някакви въпроси.
И с оглед на това, че трябва все пак да спазваме времето, аз пожелавам успех на вашата научна проява и съответно да има, защото според мен съществува кардиачна форма, тя трябва да бъде доказана в един момент. Успех на всички и хубав ден от мен.
Благодаря, професор Паскалев, за наистина добрата дискусия. Аз се надявам и за бъдеще да бъдете наш гост и непрекъснато да напомняме на колегите за това заболяване и да търсим нашия кардиологичен пациент, който ще се прояви. Наистина е невъзможно да няма такава форма, но просто е неразпозната към момента. Благодаря и на фирмата Sanofi Genzyme за оказаната наистина помощ и за наистина добрият симпозиум, който се получи. Уважаеми колеги, аз бих искала да обявя почивка след първата научна сесия, която протече тази сутрин. Време е за обедна почивка. След 3 часа отново ще бъдем тук с научната програма. 3 часа или 1 часа лондонско време. Dear colleagues, I would like to continue with to end this morning session. Here is time for the lunch, and I would like to invite you here again at 3 o'clock Bulgarian time or 1 o'clock p.m. London time. Then we will continue with the second part of our Saturday scientific program. Thank you.